A very good evening to everyone, and I welcome you all to CIDSCON 2021. I would be moderating today's session with Dr. Ravindra Gupta sir. And without much ado, I think we can move ahead with the first talk. Today is an exciting day filled with fungal infections and infections in immunocompromised patients, something which all infectious disease residents and enthusiasts are always looking forward to. And we have a lot of speakers lined up for the day, whom everybody have been waiting for. So we begin with the first talk with none other than the stalwart of Indian mycology of India, telling us about fungal infections, how it has gone over the year with newer fungi, newer antifungals, the challenges we are encountering, and the diagnosis of fungal infection, what's new in this field. Thank you so much.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizer for giving me a very interesting topic to discuss, diagnosis of fungal infection and what is new. These are my disclosure. We all know that delay in diagnosis for increasing mortality. So all emphasis in case of the newer techniques is how we can improve in case of turnaround time. And here, if you look into the conventional technique, here we know that in case of the critically ill patient, to collect sample from the deep tissue is a big problem. Even if you collect the small number of fungal pathogen is also another challenge. That's why the tests are of poor sensitivity and long turnaround time. Yes, we have now non-culture-based diagnosis, especially galactomannan and beta-D-Glucan, quite well utilized. Newer techniques like PCR and lateral flow assay which are coming up. Now, these non-culture-based techniques, when we are evaluating in the group of patients where the prevalence is high, it gives high test probability, so the results are good. But again, I would say that this non-culture-based diagnostic test, the turnaround time depends on the test frequency in that particular lab. If you are doing twice in a week, then your TAT would not be good. And our main attention is case of Candida and Aspergillus, and little attention to mucormycosis. So here, if you see the existing benchmark, we all know about the galactomannan, beta-D-Glucan, even Aspergillus PCR, though it's not well standardized in India, but it is being used in many centers. But the new biomarkers which are coming up, all looking into this point of care test, especially lateral flow assay. So here, if I have to say what is new, I would say the known biomarkers now evaluated in new group of patients. Because like hematologic malignancy, where the patients were much more evaluated, now it is looked into the ICU group. And point of care test, especially aspergillosis, histoplasmosis, even in Candida that is coming up. Well, there are some hope in case of mucor also there. And where I am going to give more stress is the cell-free DNA detection. Possibly that would be the future of the situation. In spite of all this development in diagnostics, we still rely on the clinical algorithm. Here also new diagnostic algorithm has come. We all know that galactomannan is much better if we do it in case of BL rather than serum, and that is being evaluated more in the traditional risk group. And here you can see easily that in the same patient, where the serum galactomannan is coming either negative, that is coming positive in case of the BL galactomannan. So in case of the ICU patient, now this BL galactomannan has been evaluated. Especially it has now been included in case of the clinical algorithm for giving or dividing the patient proven probable or putative in case of the patients in ICU. But what I like to stress is that possibly we need the combination of biomarkers. If you see that in meta-analysis of 13 studies, that when both the tests are positive, it confirms the diagnosis. If both are negative, then rule out the diagnosis. If one is coming positive, then possibly we have to repeat the test. So coming first to the Aspergillus lateral flow, there are two tests available. One is the lateral flow device, which is from OLM. Another is the lateral flow assay from IMI. Both of them are CE marketed, yet require the FDA approval. In OLM, it detects the extracellular protein secreted by Aspergillus hyperactive. And they have developed monoclonal against it, which is being utilized. We know in IMI that is against galactomannan, specific for Aspergillus, but possibly they are using another monoclonal against undisclosed antigen. Generally, the sample volume is required very low, and very small volume sample can be utilized. The test procedure doesn't take time. That's why we give the report within 15 to 30 minutes. In case of the lateral flow device, it is cross-reacting with penicillium, whereas here it is cross-reacting with fusarium and scedosporium. And when lateral flow has been compared with the BL galactomannan, whether it is proven or probable group, you can see the comparison or results showing good correlation. Now, this lateral flow has been evaluated in different group of patients. When it had been evaluated in traditional risk group of patients, at least both in hematologic malignancy, solid organ transplant, here the sensitivity is good, which have been shown. Especially if you take the cutoff of 1.5 in that situation, it is much better with the specificity in hematologic malignancy. But I would say that in case of the ICU patient, when it had been evaluated, sensitivity may not be that good. Even then, this is important because in case of ICU, invasive fungal infection diagnosis is a big challenge. If we can diagnose 2/3 of the patient by this process, it would be good. So when we look into this ROC curve, best curve is seen with hematologic malignancy. And when both these tests, lateral flow assay and lateral flow device, has been evaluated, more or less, both of them have got similar ROC curve. But when it is being head-to-head compared, this has been done in case of the hematologic group of patient, you see the sensitivity of lateral flow is much better than lateral flow device. Even the specificity is better. This reason is here, if you see the scattering which we see with lateral flow device, which is not so much in case of lateral flow assay. So my friend Martin, their group tried to have this meta-analysis, looking into this lateral flow, comparing this lateral flow assay versus lateral flow device. In BL sample, if you see in hematologic malignancy, lateral flow assay is better. Even in case of ICU group of patient, possibly the same result. And when it had been tried in serum, it is again showing that the lateral flow assay has better sensitivity compared to the lateral flow device. But friends, my presumption is what I have seen that there are several different results in different studies have been found. So at present in India, we are evaluating in multi-center both these tests. Hopefully, Indian result would give a much better picture. Now, this is the story where we are using the serum or BL sample. But this particular study which have been conducted by Kiran Ma's laboratory, they found that they can detect Aspergillus-specific antigen in the urine. They developed this particular monoclonal antibody. And when they have evaluated, they showed very good result that you can see sensitivities around 80%, false positivity only in 8% of the cases. But somehow this has not come yet in the kit form. Similarly, siderophore of Aspergillus Fumigatus, especially this is the triacetyl fusarinin C, that can be also detected in biomarker. Here it comes in the kidney excreted by this. So by mass spectrometry, it can be detected either in the BL sample or UV sample. Now coming from Aspergillus, another challenge in diagnosis is the histoplasmosis. In histoplasmosis now, similarly lateral flow tests have come. One is the Miravista Diagnostics have come up with this particular test, and it shows that both in serum and urine, the sensitivity and specificity quite good. And then there is another test which had come up, that is YDX. This is also developed histoplasma antigen in urine. You can see the sensitivity and specificity also good. Now coming to the fungal, we are using this for a long time now. And it really helps certainly in case of Candida, Pneumocystis infection. But problem of this particular test is that you have to have 21 patient sample at one go, which may not be in small laboratory. That's why turnaround time increases. Now, the same Cape they have come out with a better solution. This would be single patient testing. And they have improved the turnaround time. Now, within 1 hour, this test result can be given. I have not evaluated, but this would be a very interesting one. Now, in case of the Mucor, there is this particular kit is there, that is Mucor, that is the pathognostics, they developed Mucor genus kit. When it had been evaluated, it had seen that it's not detecting the disease much early, almost the same time as in case of culture. Though the sensitivity and specificity in another study compared with the in-house PCR, it is giving good result. But when in case of this COVID-associated mucormycosis, we have evaluated in our centers, what we have found that the sensitivity in pulmonary mucormycosis is not so good. So possibly this would be helping more in case of mucor, but though this is more pan-fungal detection assay. This is detecting the Mannan polymerization complex, MNN9P, this is the antigen, which they are detecting. This is being present in member of both zygomycota and ascomycota. So monoclonal antibody has been developed against it. You can see this can detect so many fungi, both in case of zygomycota and in case of ascomycota. But you see very interestingly, the sensitivity with mucor is much better compared to the Aspergillus. IL-6 and IL-8, I know this is a non-specific, it can be interleukin, is produced in many other diseases. But what it has been found that in case of invasive aspergillosis, especially, you can see in BL sample, there is BL sample, it is high. And even in case of this serum, when it is more than 300 picogram per ml, then it is highly specific for invasive aspergillosis. This IL-6 and IL-8 is also being evaluated in the patient prospectively. And in that situation, what it had been found that in blood and BL fluid at the time of bronchoscopy, when sample had been collected, and also on 4 days following the bronchoscopy, sample had been collected from blood. In these, if there is rise in IL-8 and IL-6, it shows that patient has more chance of mortality. So this way you can really prognostically evaluate the patient by this process. But this is my maximum interest now, because this is one of the tests, if it can count, that would be future of many of the infectious diseases altogether, not only in fungal disease. You know that the DNA comes out from the tissue. This cell-free DNA, and this cell-free DNA is also called liquid biopsy. And this cell-free DNA can be detected in the serum or plasma, and also in case of the urine. Now, by metagenomic approach, what it had been done is that when you do the whole genome sequencing, especially with this technique of bisulfite sequencing, you can have measurement of cytosine methylation of the cell-free DNA. Now, this particular methylation of each of the tissue or organ has got a specificity. On that basis, you can see how much damage of that particular organ or where from this particular DNA is coming, you can tell about it. Simultaneously, you are detecting the microbial DNA. So this metagenomic approach possibly would be very much useful. There are 2 studies already available. Look at this, both of them are online. In the first study, they developed a bioinformatics pipeline using 12 species of fungi which are causing more human infection. This has been evaluated in patients with invasive fungal disease and also in control. What it had found that this cell-free DNA is positive in 20.8% patients. But most important thing is that you see it has got a positive impact in case of clinical management. So you see this is being detected both in Aspergillus and Mucorales, but the sensitivity with Mucorales is much better than Aspergillus in this situation. This is a study where the plasma which have been stored that had been utilized. This is from the bone marrow transplant patient with pneumonia. Here, their plasma, they are detecting the same cell-free DNA from the plasma which is being stored within 14 days of diagnosis of pulmonary probable disease. What they have found that the sensitivity is around 51%. But when you restrict the samples which have been collected within 3 days of diagnosis, then the sensitivity increases to 61%. When combined with the galactomannan, it is increased further 84%. This has been evaluated again in Aspergillus and non-Aspergillus mold infection. You see, again, this particular study shows the same finding, that it is much better in non-Aspergillus like mucorales rather than Aspergillus. So this moderate sensitivity of Aspergillus, which is there, but this specificity goes, it assesses both tissue damage and guide treatment. It's all these good stories in case of diagnosis. Despite that, we have to rely in case of clinical algorithm. We all know that in immunosuppressed patients which have been developed for the drug trial sense, but now it is quite being used in patient management as well, where we divide the patient into proven, probable, and possible group on the basis of host factor, then clinical features, and mycological criteria. So if you look into this host factor, there is some update in 2020. And this update is that T-cell immunosuppressant and B-cell immunosuppressant had also been included. Also, the graft versus host disease has been included. In case of the radiology, yes, ERP sign and so-called halo sign is there, but also weight-shaped and segmental and lobar constellation has been included. Aspergillus PCR is also included. So this ERTC MSD helps in traditional list. But we all know that there are new risk groups where we cannot use this ERTC MSD classification because of different host factors. This coming in diabetes, influenza, COVID-19 patient, even this Bunia virus infection, which is now going from China, Taiwan, Korea, in this region, which is producing severe fever with thrombocytopenic syndrome, here also invasive aspergillosis are increasing. So in case of traditional group, we know that imaging halo sign, ERP sign helps. Especially halo sign comes much earlier than ERP sign. But then these signs are not useful in immunosuppressed patients. So what would be there in case of the immunosuppressed patient? I rather try this pathogenesis, how this chronology of things happening, from that whether imaging can be calculated or not, or imaging can be interpreted or not. After inhalation of the conidia, there is attempt for colonization by hyphae formation. To prevent this hyphae formation, macrophage tries. But if the fungus wins, then there would be bronchoalveolar dissemination. Once there is dissemination, then they try to enter the blood vessel. But here, what prevents the entry? It is the neutrophil which tries to prevent the entry. So in neutropenic patient, there would be entry of this, which is causing thrombosis infarction. That's why we see halo sign. But in case of this group, non-neutropenic, there is not halo sign, which we can see because there is no entry in the blood vessel. So what we can see in this type of patient? We can see either the centrinular micronodules, or you can see localized bronchiectasis or tree in bud appearance. So if you look into this now algorithm which have been put for aspergillosis in ISO, here you cannot use the MSD. So here the entry criteria was put as the Aspergillus positive in the respiratory culture. That would really have the entry that is acting as a host factor here. So here what it happened now with the GM and PCR had come. So it is not only Aspergillus positive in the respiratory culture, even GM positivity or PCR positivity has been taken into consideration. Then there should be at least one sign and symptom: fever, recurrent fever, pruritic cough, chest pain, dyspnea, hemoptysis, worsening of respiratory insufficiency, or at least one host factor or semi-quantitative Aspergillus culture positivity. And imaging shows, as I've said, there is no clear-cut so-called halo or Yerkes side, any abnormal imaging to be taken in. But this has been modified by Bassett and Bauja. They said that in host factor, rather these are more important non-neutropenic group, chronic airway abnormality, decompensated cirrhosis, severe influenza, even galactomania. Now, influenza-associated pulmonary aspergillosis in ICU. Here the problem is, here you cannot do always the bronchoscopy or do the BL sample. That's why it's very difficult to classify that there should be presence of aspergillus in the respiratory tract so that you go through the ASP ICU clinical algorithm. So what they try to develop, if you do the bronchoscopy, now in a good number of patients of invasive, this influenza-associated pulmonary aspergillosis, you can see this tracheobronchitis. If there is tracheobronchitis taking biopsy, if it is proven, then it is a proven case of invasive aspergillosis. But even then, if it is not having, the biopsy can be taken. If this lesion is there, along with that, if galactomania comes positive, then it's also qualified for probable invasive aspergillosis. Now, when I do compare the influenza associated with COVID associated scenario, first thing is that in both these groups, very rarely you can use the URTC MSG, that clinical algorithm. More problem in case of the kappa is that we even don't see tracheobronchitis so commonly as it has been seen in influenza associated. Even in imaging, there is hardly any difference which is seen whether it is confirmed aspergillosis or without fungal infection. So what we have suggested is that multiple pulmonary nodule with these symptoms, with hemoptysis pleura, think about this particular case. Can it be kappa or not? Even if you see serum galactomania, which is still being positive, quite number of patients in influenza associated is not so much positive in case of COVID associated. So in COVID associated, one side there is problem of sample collection from the respiratory tract. At the same time, because of the chance of getting infection, at the same time, even serum is not so good. So we have developed this consensus guideline from our international society with the European Confederation of Medical Mycology. If there is tracheobronchitis, then if you can take biopsy, it can be proven. But if you cannot do the biopsy, if there is ulceration seen, nodular pseudomembrane seen, and if there is even serum is positive, or if it is a serum is positive, or if you do the BL sample, that comes positive, it is probable. In pulmonary group, as many a times you don't do the BL sample. So there is another thing which we have brought here, that is the non-bronchoscopic lavage sample. In non-bronchoscopic lavage, we said that it should have much higher index of galactomania. Then it can be classified in the possibility. Friends, what about the improvement in diagnosis or clinical algorithm? The medical mycology is so interesting and so problematic. We are seeing changing of host. We are seeing introduction of new management. We are seeing changing environment. We are seeing changing pattern of presentation. We see newly recognized mold pathogens are coming. So it's a moving target. And here the diagnosis is much more difficult. So summarizing what I tried to tell you within this short period of time, think of fungus in your patient. That is first important thing. Lateral flow possibly improve the diagnosis of invasive aspergillosis and histoplasmosis. Yes, Aspergillus PCR still needs standardization in the Indian scenario. But I'm really very much interested with this cell-free DNA metagenomic approach for fungal diagnosis. Still in ICU, diagnosis of invasive aspergillosis is a problem. I think this influenza-associated or COVID-associated, whatever the diagnostic algorithm is there, it needs validation in the Indian condition. Mucormycosis, yes, we have got one kit, but possibly we need better biomarker and molecular diagnosis of fungal infection. At the end, I like to invite to this particular conference. This is now finalized in 2022 in case of September month 2024. Friends, with lot of difficulty, we could bring this Congress first time in India. I wish all of you attend this conference. Thank you for your kind attention.
Thank you, sir. Thank you so much for such an interesting lecture. It's always a pleasure listening to you, sir, and how you make medical mycology just so interesting and simple. We have so many questions lined up for you, sir. Dr. Deepak is asking a role of beta-D-glucan in diagnosis of Candida UTI.
Beta-D-glucan, of course, is good in case of the both Candida and also in case of the pneumocystis diagnosis. These are the two areas, though this is a pan biomarker, except in crypto and mucor, it is coming positive. So this test, if it comes, but possibly I always suggest instead of one test, two successive tests, and that would give much better result. And this beta-D-glucan has been evaluated well by Dr. Ram in Apollo Chennai, where they have shown that if it is more than 150, that really helps in case of the diagnosis. Or if it is below a certain level, you can also exclude the diagnosis. So both ways it can really help in diagnosis of Candida in that sense.
Thank you, sir. And so Dr. Raksha is asking, sir, can we use lateral flow assays for prognosis or response to therapy?
We have no experience much yet about lateral flow. Lateral flow can be quantitative estimation, can also be done. So there is a chance that it can, like in case of galactomannan, it can be used possibly in case of prognostic marker. But we need to evaluate. We are at present in multi-center comparing the galactomannan, this lateral flow along with galactomannan, both the lateral flow assay as well as lateral flow device, we are comparing. Hopefully, because at least the preliminary result shows the sensitivity is low, but at least the results are very quick. So we need to have this test. And very soon, when the result is fully analyzed, it would be very useful for this country as well.
Definitely, sir. So there's another question by Dr. Chavi, which says recently the cutoff of galactomannan in serum has been revised to 1. But a few IPA patients still have serum galactomannan less than 1 has been our experience.
I would say that it all depends on what is your objective. If you are trying to exclude, then it is better to have a low cutoff, like 0.5 or 0.75. That would exclude the disease. But if you are diagnosing something with this galactomannan, then I would say that you put the cutoff a bit higher. So I would not say there is any universal cutoff which can be utilized in this scenario. It is much better with the experience, people can use it. And many centers, they have used 0.5 or 0.75 or 1 or 1.5. I said the objective of the particular test would really decide whether we want a low cutoff or a high cutoff.
So Dr. Anupati wants to ask that why QOH is positive in some cases, but fungal growth is still negative.
Why?
Why QOH is positive, but fungal growth remains negative in some cases.
You know, this particular phase, in case of COVID-associated mucormycosis, a lot of people say smear is coming positive, but culture is not coming. Opposite also happened. They say that smear is negative, but the culture has come positive. In case of the fungi, especially mucor, the problem is that if you have somehow the tissue or whatever the material you have taken, if you have grounded that material or homogenized that material, then you will fail to diagnose or fail to get the culture. The reason is this is very labile hyphae. There is no septa. So if there is leak at one end, it would be affected the whole hyphae. So there is always failure in case of culture. But I am more happy to detect the fungus on direct microscopy. Suppose if direct microscopy comes negative, culture comes positive, then I am a bit skeptical about the diagnosis because all these fungi are saprophytic. If it comes as a contaminant in the laboratory, then there would be more problem.
Thank you, sir. So another question by Dr. Chavi, negative predictive value of beta-glucan in histoplasmosis.
Pardon?
The negative predictive value of beta-D-glucan in histoplasma cases. Histoplasmosis.
In case of histoplasma, I would say that it is that galactomannan is more commonly being used because there is a cross-reaction between the galactomannan as well as in case of histoplasma. It had also been seen a cross-reaction with the penicillium. So sometimes when you don't have the histoplasma antigen kit available, at least this kit, if it comes positive, again, there is no cutoff value which we can say about it, 0.5 or 0.75. At least if it is more than 0.5, suspect the disease. That is the most important thing. But I would suggest that you try to diagnose the disease by showing the direct microscopy and culture. But this particular histoplasma, the lateral flow which is coming up, I have not evaluated it yet. The company is sending us for evaluation. This particular test, if it comes useful, that would be really change the diagnosis, because histoplasmosis diagnosis is always a challenge, even when clinician suspects it, because if you take the bone marrow, then also the diagnosis is not more than 50%. So there is always problem in case of histoplasma diagnosis. Culture takes long time. So microscopy also, it requires a very expertise, which is not available in all the center. So I would rather feel that this particular, because histoplasma antigen was expensive and histoplasma lateral flow, hopefully it would be much cheaper. And that would really modify the whole management in case of histoplasmosis by quick diagnosis.
I think this is the last question we can take. Dr. Shamila is asking, what is your final take on commercially available fungal PCR kits?
Fungal PCR, I am still not very clear which I should recommend in that sense, because there is none of the PCR kits have been multi-center evaluated. Mostly there are some of the kits. I would say that again, experience says that possibly we have to rely now more on the lateral flow rather than going for this PCR, because PCR, I would rather very much interested in this cell-free DNA aspect. And cell-free DNA, these two papers which are there in CID, both of them are online. Both of the papers are very exciting. And both these papers have shown that the possibly if we do this cell-free DNA detection, that would modify the whole picture. That is again the same PCR process, but it is having got different types of primers, because cell-free DNA are very small, and because of the small, you have to have multiple copies to detect it. I can discuss if somebody wants to discuss the cell-free DNA. That's my excitement at present.
Thank you, sir. So there's a long list of questions people are still trying to ask you, but in the interest of time, we'll come back to them if the time permits after some talk, or if you can just type the answers, because there's so many questions everybody wants to ask after such an exciting talk. Thank you again for such a wonderful talk and taking us to the medical mycology from the very basics to the latest that's happening in the field.
Thank you very much.
Thank you so much, sir, for the same. Moving ahead in the field of fungal infection, a lot of controversies which last year has seen with mucormycosis and several other things which are on the panel. The next talk for the day is Controversies in Fungal Infection. And I invite Dr. Ram Subramaniam, sir, to kindly take on the mic and Controversies in Fungal Infection.
Good evening, everybody. It's my pleasure to be with you this evening at the CIDSCON 2021. I have been asked to speak to you about controversies in fungal infection. And over the next 20 to 25 minutes, I shall try to cover what I feel are currently the controversies and what probably may be some answers to it. The disclosure, I have been part of advisory boards, have received speaker fees, travel grant, and research grants from several companies, including Pfizer, MSD, Sanofi, and more, but there is no conflict of interest with this talk. I have tried to list about 10 controversies with regard to fungal infections in humans, starting with the fungal taxonomy, antifungal prophylaxis, role of biomarkers, empiric versus preemptive therapy, combination with antifungal agents, azoles versus echinocandins, evaluation of Candida, endophthalmitis, de-escalation of antifungals, diagnosis of invasive fungal infections in COVID, and of course, several unanswered questions and controversies. With regard to fungal taxonomy, this is a simplified version of a clinician's understanding. When I have a yeast, it is Candida in general. When I have a mold where hyphae are seen, it could be pigmented where it is demeticious due to Majorella, Cladophyllofora, Curvularia, or Bipolaris, or it is a mold which is septated, in which case it could be possy or aseptate like Rhizopus, Rhizomucor, Mucor, Cunningham-Ella, etc., or it is septated where it is either Aspergillus or Fusarium or Pseudosporium and more. But things have changed over the last century. What was called Trichosporum capitatum in 1942, metamorphosized into Geotrichum capitatum by 1977, and then Saprochaete capitata. Alascheria boydii in 1922 evolved into Pseudo-Alascheria boydii and then Pseudosporium boydii. So, like this, there have been several changes, and some of them have been quite stark. Absidia ornata is now Lichthemia ornata. Aspergillus fumigatus in the broad sense may include Fumigatus, Fumigatia finis, Lentulus, or Neosartorio udagave. Aspergillus terreus, again in a broad sense, could include not only terreus, but alabamensis. Albicans could include Dubliensis. Glabrata could include Brachyrensis and Nivariensis, and Parapsilosis could include Metapsilosis and Orthopsilosis. We are no longer in a situation where we depend on morphology to identify an organism. We are now into sequencing. And this has led to several dramatic changes. Aspergillus fumigatus is now referred to as Neosartorio fumigatus. Bipolaria is now referred to as Curvularia. Penicillium marnifae has become Telluromyces marnifae. Pseudo-Alascheria has become Pseudospora. Pseudosporium prolificans is now changed to Lamentospora prolificans. Candida lusitania is called Clavispora lusitania, and cruzi, Candida cruzi, is called Pichia cruzi. Candida guillermondi, Merozyma guillermondi. But what is the relevance of these controversial names to a clinician? They do have relevance because the diagnostic assay is different. We help to understand whether it is colonization or infection based on the species and identification. The susceptibility testing and the resistant patterns vary, which may lead to different therapeutic decisions. So we need to keep up to date with these changing identification through genetic sequencing, and that is a major aspect of invasive fungal infection these days. The second question is, who should receive antifungal prophylaxis? Now, unfortunately, things are not as simple as what was seen earlier. As you see in this, my father once said to me that if you see a red car with a horse, that's a Ferrari. But this may not be so. And the reason why antifungals are given as prophylaxis is because it significantly reduces all-cause mortality compared with placebo or non-systemic antifungals, especially in allogenic HSCT recipients and high-risk leukemia patients. But who should be given prophylaxis? It is seen that almost 11% of patients due to HSCT die of infectious reasons, and among these, 1/3 are fungal in etiology. So we need to be very careful in whom antifungal prophylaxis can be given. If you classify the risk as low, intermediate, or high, in general, people who are neutropenic for less than 7 days with other hematological malignancies or autologous stem cell transplant are at a low risk where prophylaxis is not indicated. Intermediate would be those who have neutropenia for a couple of weeks, include AML, ALL, and MDS in consolidation chemotherapy, and allogenic stem cell transplant, which is matched without GVHD. But those who definitely require prophylaxis are those who come under the high-risk group, patients who are neutropenic for more than 2 weeks, patients with acute myeloid leukemia or acute lymphatic leukemia and relapse, MDS in induction or salvage chemotherapy, and allogenic stem cell transplant recipients, especially with GVHD. So these are the patients who now should be targeted with prophylaxis. If you look at newborn babies, prophylaxis is mainly indicated for children who are preterm, who are less than 1,000 grams, and who are in a situation where the prevalence of fungal infections or invasive fungal infections is more than 10%. Pediatric ICUs, it is controversial. In adult ICUs, it has been shown that chlorhexidine bathing can minimize the risk of invasive fungal disease, but we need to target patients in the pediatric ICU better with regard to antifungal prophylaxis. If you look at cancer and stem cell recipients, as I said earlier, it is mainly acute myeloid leukemia, recurrent or high-risk acute lymphatic leukemia, allogeneic hematopoietic stem cell transplant, and severe aplastic anemia where the neutropenia is prolonged. But when giving in these situations, either as primary or secondary prophylaxis, therapeutic drug monitoring is indicated. You need to monitor side effects, drug-drug interactions, and also probably do surveillance biomarkers. With regard to solid organ transplant, the prophylaxis can be yeast, mold, or for pneumocystis, which we shall see subsequently. But what primary antifungal prophylactic drugs is recommended? This has also changed over the decades. There was a recent meta-analysis in JAMA, which looked at the comparison of antifungal prophylactic drugs in patients with hematological disease or undergoing HSCT, and concluded that these findings suggest that voriconazole may be the best prophylactic option for patients undergoing HSCT, and posaconazole may be the best prophylaxis for patients with acute myeloid leukemia or myelodysplastic syndrome. So we are getting a little more clarity in this aspect. If you look at children with solid organ transplant, it varies with the type of organ transplanted and the risk of invasive fungal infections. For liver, it is predominantly Candida or maybe Aspergillus. For lung and heart, it is Aspergillus. For pancreas and intestine, it is mainly Candida. You should also understand the duration of prophylaxis. For liver, it is generally 4 weeks. For pancreas and intestine, again, 4 weeks. For heart, it may be up to 6 months, and for lung, as long as 1 year. For pneumocystis jirovecii, prophylaxis may be generally about 3 months, but may extend longer, especially if the person has prolonged immunosuppressive therapy. For adults with AML or MDS, posaconazole is probably the drug of choice, though fluconazole follows up. But what is more important is that amphotericin deoxycholate or aerosolized amphotericin deoxycholate is discouraged. Aerosolized liposomal amphotericin can be given only in combination with fluconazole. So these are, again, developments which we have learned in the last few years. The third question is, should we suggest empirical antifungal therapy for patients at high risk in ICU? You know that approach to invasive fungal infection treatment can be classified as prophylactic, empiric, preemptive, or directed. Prophylactic is what is called fear-driven. Empirical is what is called fever-driven. Preemptive is called evidence-driven, and directed is treatment-driven. So prophylaxis is given to patients who do not have any clinical evidence of invasive fungal disease or infection. They do not have any positive cultures, and radiologically there are no changes. Prophylaxis is generally recommended if the prevalence of invasive fungal infection in the population concerned is generally 5 or at least 10% or more. Empiric therapy is again when they don't have symptoms, but they have persistent febrile neutropenia in spite of broad-spectrum antibiotics. There tends to be an increased use of antifungals in this group, and that is the reason we have now moved on to preemptive therapy, where either they should have a positive biomarker or they should have some radiological evidence, in which case, even if they don't have evidence of invasive fungal disease, the possibility of invasive fungal infection is high. You cannot exclude the fungal infection disease, and thereby you need to start antifungal therapy. Of course, directed is when you have definitive evidence. So if you look at the evidence available, preemptive therapy has been shown to reduce the rate of antifungal use, and yielded a 12-week survival rate of 63.6% for patients with invasive fungal disease. Preemptive therapy also decreased treatment costs by 35%, but was associated with more invasive fungal disease than empiric treatment, but survival rates were similar between the two groups. So this led to the recommendation that preemptive therapy be used in patients who are immunosuppressed at risk of invasive fungal disease. This study also showed, published a decade ago, that if you compare the survival in patients who receive preemptive therapy versus empiric therapy, the benefits favored those who are given preemptive therapy. But what about the role of preemptive therapy in ICU, not in immunosuppressed patients? The Empiric study said that the primary endpoint, which was a survival to 28 days free of invasive fungal infection, occurred in 68% and 60% of patients respectively who were given micafungin and placebo, which was not significant. And the overall survival was not significantly different between the two groups. That is the group where empiric therapy was used and in which preemptive therapy was used. However, the incidence of proven invasive fungal infections during follow-up was lower in the therapy where empiric micafungin was used. So again, we see that we can decrease the occurrence of fungal infections if you use empiric therapy, but there is no survival benefit. Moreover, if you use only empiric therapy, the costs and exposure to antifungals is also much reduced. So for patients in the intensive care unit, preemptive therapy is probably more in favor and rather than empiric therapy. The role of biomarkers. What is the value of 1,3-beta D-Glucan in current practice? This table shows some of the false positive results of 1,3-beta D-Glucan, which includes contamination in the laboratory, bacteremia due to Streptococcus and gram-negative bacteria, contact with surgical sponges and gauze, hemodialysis patients where cellulose-containing filters are used, but I'm told reliably, but this is no longer used in most hospitals, treatment with immunoglobulins, beta-lactamase inhibitors, and also certain anti-neoplastic treatments. False negative results can happen if there is hyperbilirubinemia or hypertriglyceridemia, or if already the patient is on prophylactic or empiric treatment, or even azithromycin and pentamidine can cause false negative results. The conclusion is that 2 consecutive positive blood tests for 1,3-beta D-Glucan excludes most frequent and obvious causes of false positivity, are associated with a high suspicion of invasive fungal infection. Its persistence or elevation in confirmed mycosis in antifungal treatment may be associated with a poor prognosis. So you need to do serial beta D-glucans, and if 2 are positive, then the chances that this is a fungal infection is very, very high. But then what is the cutoff we can take for positivity? The general cutoff used is 80. But in a study done in our hospital, we showed that 80 was having a very poor positive predictive value. The sensitivity generally for beta D-glucan is believed to be about 76% and the specificity 85%. But 80 may be a poor cutoff. We found that if the value was more than 400, that had a strong indicator for a positive predictive value, especially if you're using a single value in places like India, which have limited resources. What about negativity? Does the negativity of a biomarker combination allow early suspension of antifungal therapy? There are several antifungal biomarkers which can be used. Fungal biomarkers, mannan, cacta, beta D-glucan. We also have galactomannan, aspergillus. This is for mainly aspergillus. In our hospital, we use sometimes a combination of beta D-glucan and galactomannan. And it was shown, this was a study where they looked at comments from experts who said that the negativity of 2 or more biomarkers of invasive fungal infection supports the suspension of many empiric treatments and is an essential element of adequate antifungal use policy. So very few hospitals in India have access to these biomarkers, but if it is available and if you especially have a combination where you can do more than one biomarker in a serial fashion, it may be useful in suspending therapy. But as I still said, the marker cutoffs are still controversial. If you're looking at the biomarkers, especially of galactomannan in the lung, there is still a lot of confusion whether the positivity can be due to colonization or what should be a cutoff. Should we resort to the bronchoalveolar lavage cutoff of 1, or should we resort to a higher cutoff, especially if the sample is taken from the endotracheal tube or a bronchial wash, where the cutoff may be as high as 4. So we are still waiting to get more clarity in these areas. The 5th controversy is, what is the place of combination antifungal therapy? Is it beneficial? The reason or the rationale for combination antifungal therapy is that the occurrence or the development of newer antifungal agents is not keeping in pace with the increasing resistance seen among fungi. We also believe that a combination can improve the spectrum. It can increase the fungicidal effect, probably due to synergism, and also minimize the occurrence of resistance to antifungal agents. Definitive evidence is seen in cryptococcal infections where a combination of amphotericin B plus 5-fluorocytosine is used. In some subsets of Aspergillus where there is a high galactomannan, a combination of voriconazole plus anidulafungin was found to be useful. And in some Candida infections, especially of the CNS and endocarditis, there has been benefit using combinations of amphotericin B and 5-fluorocytosine. But unfortunately, in most studies, there have been contradictory results. Some have shown synergism, some have shown antagonism. There is also marked heterogeneity in the results. It is very difficult to compare the drug levels from animal studies and correlate it to human studies. There are no standardized protocols. The studies are retrospective and very small. For example, the clinical studies for amphotericin, that combination was studied, is only about 10 so far, and even they have very few cases. So far, there has been no significant mortality benefit which has been shown. There have been several other agents, including calcineurin inhibitors, statins, and iron chelators, which have been used as combination with antifungals. In fact, Dr. Rajiv Soman is a very staunch supporter of using iron chelator as combination for treatment of mucor. But unfortunately, one study did not show benefit, but still that we cannot draw concrete conclusions from that. But most often combination therapy is used in salvage, where it is believed you have everything to throw, including the kitchen sink, in a patient who's not responding to conventional treatment and is deteriorating. There have been several combinations which have been used, including terbinafine and diazole combination, amphotericin B plus azole, amphotericin B plus 5-fluorocytosine based on their mechanism of action, which if you look in theory, can sometimes be antagonistic rather than synergistic, even though some studies have shown benefit. The main controversies is that with regard to combination therapy for Aspergillus, salvage therapy probably is the only role, though, as I said, voriconazole plus anidulafungin in certain cases has shown benefit, even though voriconazole with caspofungin did not show benefit. It beats me how. And it is also important to remember that it takes about 5 days for voriconazole to reach steady state levels. So if you combine voriconazole with another agent like an echinocandin, at least in the initial part of treatment in a very sick patient, this probably may be beneficial. With mucor again, there is a lot of confusion. Amphotericin has been combined with caspofungin or with posaconazole, and there have been some benefits seen. For a patient who had polytrauma with refractory mucormycosis, a combination of interferon G with nivolumab was studied in Germany and found to be useful, but these are anecdotal. And caspofungin has also been combined with calcineurin inhibitors, sirolimus and others, and have shown some benefit. But we are still not sure whether the way forward is with combination therapy. The next is the choice of antifungal. Should we use echinocandins or azoles? You know, in India, where there is limited resources, echinocandins may not always be the first line of antifungal agents. So if you can't afford a Volkswagen, I think you have to travel in an auto. But if you look at most societies, including the IDSA, the ESCMID, the European Expert Opinion, the Canadian Guidelines, or the German-speaking Mycological Society, all of them recommend fluconazole in stable patients and echinocandins in sick patients. But where preferable, try to use echinocandins because the outcomes are better. That is where it is leading to. Whether this is used due to a pharma lobby pushing echinocandins forward, we are not sure yet. But so far, we have tried to use echinocandins as the empiric or the preemptive or specific treatment wherever candidemia is suspected. The ECIL6 recommendation also suggests the role of macafungin or anidula or caspo as A1 recommendation in most patients with the malignancy, and fluconazole in patients probably who are stable. But in an ICU, how do you define stability? Is it only based on hypotension? Do you look at other factors? A recent study looked at empirical and targeted therapy of candidemia with fluconazole versus echinocandins in the ICU. And it concluded saying that the results suggest that using fluconazole for the empiric or targeted treatment of candidemia is not associated with a worse prognosis than echinocandins in non-neutropenic patients. So remember, this is in non-neutropenic ICU patients in the general ICU, and this warrants a closer look. So I am still a little old-fashioned, and I use fluconazole more freely than my colleagues, especially if the patient is stable. So I think this should be looked into for, again, better plan of therapy in future. This is a paper which we discussed recently in our department, the role of dilated fundus exam in candidemia. The recommendations, this is the IDSA recommendations, which say that all patients with candidemia should have a dilated retinal exam, preferably performed by an ophthalmologist within the first week of therapy in non-neutropenic patients. And for neutropenic patients, it is recommended to delay the exam till neutrophil recovery happens. Now, this is done because the impact of endophthalmitis can be debilitating because the person can lose vision if not diagnosed properly. The therapy was thought to be different. Apart from your systemic therapy, you had to give intravitreal antifungals and probably also subject sometimes the patient to a vitrectomy. And it was believed that the benefits of a dilated fundus examination far outweigh any risks it may offer. But in this paper, they looked and found that the incidence of endophthalmitis significantly diminished from the period 78 to 93 compared to 94 to 2007. The incidence of endophthalmitis was dramatically lesser. And it was also seen that there was no difference between the rates of reported chorioretinitis or endophthalmitis with prompt ophthalmic examination. All patients with presumed Candida chorioretinitis die or exhibit improvement of ocular lesions with prompt systemic antifungal therapy alone. In addition to systemic antifungal therapy, the systemic antifungal therapy alone resulted in improvement in all cases where the patient did not die. So it is said that if you treat with systemic agents, it is good enough. Those with endophthalmitis will respond adequately without changing management. Poor outcomes are associated with invasive treatment, including intravitreal antifungals and vitrectomy. And ophthalmic evaluation is probably reasonable if the person has ocular signs and symptoms. And moreover, epidemic of adenovirus infections spread by ocular examination with ophthalmoscopes, especially in premature infections, can cause mortality. So ophthalmic dilated fundal examination is not as safe as it was thought to be, and probably in the current age, it makes no difference. The eighth question is, what is the role of de-escalation as part of an antifungal therapy? We need to innovate and look at different ways rather than once you start antifungal, continue it for 14 days. There were two papers I've written here. The antifungal de-escalation is safe in critically ill patients treated for suspected or documented candidiasis in, again, non-neutropenic patients in the adult ICU who are critically ill with proven or suspected candidiasis. Systemic antifungal therapy de-escalation within 5 days was not found to be associated with the increased 28-day mortality. So you can de-escalate. This de-escalation can be in the form of IV to oral or change from an echinocandin to a azole where it is acceptable. And similarly, another paper also, this was published, I think, a couple of years ago, said the duration of antifungal therapy was significantly shorter in patients with de-escalation compared with without de-escalation, 6 versus 13 days. And no significant difference was found in the duration of mechanical ventilation, length of ICU stay, or ICU mortality or 1-year mortality. So you don't need to continue the same echinocandin for 14, 15, 16 days, depending on the response, and you can definitely de-escalate earlier. Lastly, the dilemmas in diagnosis of COVID-associated invasive fungal infections. If you look at COVID, we have learned a lot of lessons from influenza, where there is an increased risk of secondary bacterial infection and fungal infections. And it was believed initially that COVID also had significant increases. And subsequently, we have learned that the occurrence of secondary bacterial infection is not very high with COVID compared to flu. What about COVID-associated pulmonary aspergillosis or COVID-associated mucormycosis? The occurrence varies anywhere from 4 to 35%. It is very difficult for just to look at clinical and radiological findings in a patient with COVID pneumonia and pick up aspergillosis. There is very poor sensitivity of biomarkers. For example, the serum galactomannan level in influenza, the pickup for aspergillus is as high as 60%, whereas the serum galactomannan is detected positive in only 20% of patients with COVID and pulmonary aspergillosis. Moreover, sampling difficulties also make it difficult in diagnosing pulmonary aspergillosis because people are reluctant to do bronchoscopies for various reasons. The COVID-associated mucormycosis, this is a paper from Atul Patel in Ahmedabad. They showed a prevalence of 0.27%. We are still not sure what the predisposing factors for COVID is. It was believed to be only the incidence of hyperglycemia resulting from steroid use, but this may not be the entire story. Is surgery mandatory for patients with COVID? Can we get away by using antifungal therapy in patients with minimal sinus mucor infections? And the duration of therapy. How long do you give induction with amphotericin B? How long do you give maintenance with an azole? These are questions which I don't think we'll have answers in the near future. Lastly, there are several questions which are still unanswered. What is the ideal cutoff for biomarkers, as I mentioned earlier? Is amphotericin B still the first line of antifungal therapy in severely ill immunocompromised? I'm talking to liposomal amphotericin B. Are liposomal formulations definitely more effective? What about the use of conventional amphotericin B in resource-limited settings? Because the role of conventional amphotericin is strongly discouraged by all guidelines. But is there a role for various reasons? We know it increases the risk of nephrotoxicity, but does it mean that's the end of conventional amphotericin B? What's the total effective therapy dose of amphotericin? Is it 1.5 grams? It is 2.5 grams. Persistent fever with antifungals in neutropenic patients. How will you approach? Role of prophylaxis in COVID-associated fungal infections. In patients with high risk of COVID-associated pulmonary aspergillosis on a ventilator, do we need to give them prophylaxis? Because of the increased incidence of COVID-associated mucor, do we prophylax these patients? And how long is maintenance therapy after successful first-line therapy needs to be continued? So these are all questions which I think we may never get a proper answer. But in a world where we are depending on evidence, as this one says, a wise doctor once wrote, most of our handwritings look like that. So do we always depend on evidence? There is research evidence, but we need to understand that it is not only evidence which makes a decision. We believe that patients' preferences and actions for various reasons, including economy, the clinical state and the circumstances of treatment, all of this have an equal role to play in managing a patient. So I would like to leave you with these words that evidence does not make decisions. People do. So we have evidence. We can resort to evidence in several cases, but I would like to urge you that we need clinical equipoise and probably combine the clinical state, circumstances, patient's preference and actions along with evidence to make sensible decisions and choices. Thank you very much.
Thank you, Dr. Ramasubramanian. It was really an elaborate presentation, and we could get insight into so much of controversies in the fungal infection. And still, at the end of the slide, we came to know still there are so many things which are unanswered, and we are yet to find the answers to all this. Thank you so much, sir. And I think there are not many questions so far. So since there are no questions, and it is possible that by the end of the session, we may find some questions. So let's go to the next presentation then.
I have asked a question.
Okay. Yeah.
I asked Ram that most important question is to be or not to be. That is diagnosis. Most important controversy in case of fungal disease.
Perfect. Perfect, sir. So our next speaker is Dr. Divya Devdhar, who is Associate Professor of Department of Infectious Diseases, and she will be talking on endemic mycosis, like blastomycosis, Coccidio Histoplasmosis, etc. All these infections which are there as a common primary pathogens. So over to Dr. Divya Devdhar.
A very good evening to all. At the outset, I would like to thank the organizers for giving me this opportunity. The topic given to me today evening is endemic mycosis. The overview of my presentation would be introduction, followed by distribution and epidemiology. Subsequently, I'll be taking you through a series of cases. I do not have any conflict of interest or disclosures for this presentation. Endemic mycosis includes a group of diseases caused by dimorphic fungi. These fungi exist in different forms in different temperatures. Their impact on global health is not very well understood, and they have a variety of clinical presentation and hence pose many challenges in the diagnosis of these fungal infections. These are fastidious organisms, and hence there is a paucity of diagnostic tests. Even if correctly diagnosed, the therapy can be long and toxic. So why are we seeing an increase in the incidence of these infections? There is an increase in the population of immunocompromised patients like HIV/AIDS, leukemia, lymphoma, cancer patients. An individual's immunity plays an important role in the pathogenesis of infection caused by these fungi. Increase in travel causes an exposure of these organisms to a non-immune host, and this is an important reason for the rising incidence of these infections. So with this, let us look at some of the distribution of these mycoses. So some of the fungal infections like aspergillosis, candidiasis, cryptococcosis, dermatophytosis, pneumocystis jirovecii are present worldwide, although they have an epidemiology which vary from country to country. Whereas some of the others like histoplasmosis, blastomycosis, Coccidio Domicosis, Paracoccidio Domicosis, Sporo Trichosis, penicilliosis, or Telluromyces, Conidio or Basidio-bolomycosis have a restricted distribution. So with this introduction, let me take you to some of the cases that we will be seeing in today's presentation. So my case one is a case of a 38-year-old businessman from Kolkata. He presented to us with fever, difficulty in walking for 9 months duration. He had bilateral flank pain for 8 months duration and a significant weight loss. He was evaluated at his hometown with ultrasound and CT scan of the abdomen, which had revealed bilateral enlarged adrenal glands measuring about 8 centimeters each. He was started on empirical antitubercular therapy based on the FNAC which was done and which revealed extensive necrosis of the adrenal lesion. However, after 2 months of antitubercular therapy, he did not have any relief, and that is why he presented to us. His examination was unremarkable. His laboratory findings were almost normal, except in the liver function test, we see an altered AG ratio, suggesting that there is some hypergammaglobulinemia. This is the imaging of his abdomen. So CT scan of the abdomen revealed enlarged adrenal glands, and that is why adrenal glands were biopsied. So when in the biopsy specimen of the adrenal glands, there were extensive necrosis with many intracellular yeast-like organisms which were suggestive of histoplasmosis. So in this slide, you can see that there are many yeast cells which are seen as white rounded lesions which are representing histoplasmosis. So let us look at the epidemiology of histoplasmosis. We know that histoplasmosis is present all over the world, and these are the areas marked in purple which shows a global burden of histoplasmosis, whereas when we look at Indian subcontinent, histoplasmosis is endemic in the Gangetic areas, and it is seen mainly in these areas. So what happened to the clinical features and how do they represent? So this is a publication done in way back from our institution, which showed that the main important clinical features are fever and weight loss, and the other ones like oropharyngeal ulcers, lymphadenopathy can be a minor form of the clinical presentation. Looking at the laboratory investigation, the main investigation shows either anemia or pancytopenia in case of bone marrow involvement, or it can lead to, or it can be adrenal enlargement in few cases. What clinches the diagnosis of histoplasmosis? So if there is a disseminated histoplasmosis involving the bone marrow, and we see that the cell lines, all the cell lines are low, then bone marrow aspirate and refined biopsy will clinch the diagnosis. However, in some patients who present with adrenal enlargement, an adrenal gland biopsy or the FNAC will clinch the diagnosis. Whereas in a minor population, when they present with palatal ulcer, rectal ulcer, or skin ulcer, the respective areas biopsy of the tissue will clinch the diagnosis of histoplasmosis. Similarly, we also looked at whether there is a difference between immunocompromised and immunocompetent individual. So in our series of this publication, we had around 2/3 of the patients were immunocompetent, whereas 1/3 were immunocompromised. And most of them presented with fever and weight loss, which was already seen in the previous series. And if we compare the treatment and the outcome of these groups, definitely immunocompetent individual had a better outcome compared to immunocompromised individual. Coming back to our patient, so histoplasmosis capsulatum was isolated from our patients, and this is the culture plate being shown from our patient, and smear from the culture looking at the filamentous fungi, and smear from the tissue showing the yeast form of the fungi. How do we diagnose histoplasmosis? So definitely smear and culture of the tissue biopsy remains the gold standard. However, there are many serological tests which are antigen-based or antibody-based assay have also been looked into. And not to forget PCR for diagnosis of these infections. So when we look at the diagnosis of progressive disseminated histoplasmosis in advanced HIV, this is a meta-analysis which compared the sensitivity and specificity of various assays which are available. So antigen detection assay performed the best with a sensitivity of 95% and a specificity of 97%. Similarly, a recent publication which looked at diagnosis of histoplasmosis, and it revealed that antigen detection assay have a higher sensitivity in progressive disseminated histoplasmosis. It also has a great value in following up these patients who are on treatment. However, there are certain drawbacks of serological tests. There is a cross-reactivity with other related fungi, which are very common, and we should keep this in mind. And also another drawback is these tests are expensive and only can be performed in few laboratories. So what is the treatment of histoplasmosis? So induction phase of histoplasmosis in moderate to severe diseases, also with CNS involvement, is with amphotericin B, which may be liposomal or deoxycholate or the conventional form of amphotericin. When we compare liposomal and deoxycholate amphotericin B, we know that there is a higher clinical success rate. However, there is a low certainty evidence for that. Hence, in a country like India, which falls into the low and the middle income countries, even deoxycholate or the conventional form of amphotericin B can be used in treatment of histoplasmosis. When we look at the nephrotoxicity with this drug, definitely there are lower rates of nephrotoxicity seen with liposomal amphotericin B, and this has a high certainty evidence. With CNS involvement, either extension of the induction phase or an increased dosage, if the patient can tolerate, can be tried in patients with CNS involvement. Mild to moderate cases of histoplasmosis can be treated with itraconazole with a loading dose of 200 milligrams 3 times a day for 3 days, followed by 200 milligrams twice daily. Subsequently, maintenance phase of this therapy can be given with itraconazole 200 milligrams twice daily for 12 months. And this duration can definitely be considered to be shortened if we are using it in patients with PLHIV who are receiving a good and an adherent antiretroviral therapy and are virally suppressed. An alternative therapy for people who do not tolerate amphotericin B can be with high-dose fluconazole. Coming to my second case, which is a history of a 35-year-old Mr. B who presented from Manipur, presented to us with generalized papillary skin lesions and fever for 2 weeks. He had an extensive past history. He was diagnosed to have stage 4 diffuse large B-cell lymphoma in August 2010 and also received 6 cycles of R-CHOP. He was also diagnosed to have HIV infection in September 2010 and also co-infected with hepatitis B virus with 10 million viral copies. He was lost to follow-up after 2014 and had stopped his antiretroviral therapy for the past 2 years. So his examination was unremarkable except for these skin lesions which were seen in this picture. So we can see a molluscum-like lesion on his face which are seen in multiple areas, and the similar lesion was present also in his back and his upper trunk. The skin lesion was biopsied and it revealed it was consistent with penicillosis, and also the fungal culture which was sent from the skin lesion was identified as many yeast-like organisms, and it was identified as Telluromyces magnified. So you can see this beautiful picture where the wine color or the red color pigment which diffuses into the culture media, and that is pathognomic for diagnosis of Telluromyces magnified. So when we look at Telluromyces infection, it was discovered way back in 1956 from bamboo rats in Vietnam, and it is endemic in most of the countries, more so in Southeastern Asian countries, Southern China, Hong Kong, and Taiwan. And Northeastern India is also endemic where this patient belonged to. And also there are some reported cases from United States, Europe, Japan, and Australia following visits to these endemic areas. What are the risk factors for these infections? So definitely HIV infection with CD4 count of less than 100, transplant recipients, either hematological or solid organ transplant, hematological malignancies, autoimmune disorders, cancers, and diabetes. So looking at the modes of transmission, it is mainly inhalational, but however, there can be an inoculation also with these fungi. And the clinical manifestation are usually secondary to hematogenous spread. And the clinical manifestation can be very varied, and it can present with fever, malaise, anemia, lymphadenopathy, and then there are certain small percentage of patients presenting with cough, hepatosplenomegaly, skin lesions, diarrhea, and splenomegaly. The disease can be divided into categories depending on severity. So severe disease, which is characterized by multi-organ involvement with respiratory failure or circulatory collapse. Moderate disease consists of multi-organ involvement without respiratory failure or cardiovascular collapse, and mild disease is only when the patient presents with localized skin lesions. Looking at the treatment of Telluromyces, so moderate to severe diseases can be treated with induction therapy with amphotericin B, and for 2 weeks followed by a maintenance therapy with itraconazole 200 milligram twice daily for 10 weeks, and an alternate therapy with voriconazole can also be considered. Whereas mild disease induction therapy can be given with itraconazole 200 milligram thrice daily for 3 days as a loading dose followed by twice daily for 2 weeks. And maintenance therapy in these patients are seen usually the duration of the maintenance therapy is usually prolonged until there is a restoration of the cellular immunity. So in patients with PLHIV, we would wait for the CD4 count to become more than 200 for at least 6 months. Coming to my case 3, so he's a 61-year-old male from Tripura, presents with skin lesions over his right lower limb for 6 months. It starts off like a single lesion and later spreads to areas around, and there is no known history of injury or fever. He does not have a comorbid illness like diabetes or hypertensive. He has no past history of skin allergy or hypersensitivity reactions. So this is the biopsy which was done from his skin lesions, and it was sent for histopathological and cultures into the microbiology lab, and it revealed suppurative granulomas with concentric zones, central neutrophilic microabscesses surrounded by epithelioid microphage, which in turn were surrounded by lymphocytes and plasma cells. His mycobacterial smear and culture was negative. His fungal smear was negative. It did not show any fungal element, and his HIV status was also negative. But after 2 weeks of incubation, the culture on the Saboroids dextrose agar grew a fungal colony which was smooth, tan to cream in color, and microscopy of the culture isolate also revealed filamentous form of hyaline septate hyphae of small micron, 1 to 2 micron width, with conidia seen in groups and small clusters, and it was identified as Sporo species. So coming to Sporo Trichosis, it is also known as Rose Gardner's disease, and the geographical presentation occurs worldwide, but there are some reported cases which have originated from United States of America, South Africa, Mexico, and South America, whereas northeastern part of India is definitely endemic for these infections. Infection usually results from a traumatic implantation of the fungi, which is growing in the soil or the plant material into the skin or any subcutaneous tissue. It can present in various forms like lymphocutaneous infection, osteoarticular sporotrichosis, systemic infection. It can evade also the central nervous system and pulmonary sporotrichosis. So the treatment of localized disease is with itraconazole, 200 milligrams once a day is the drug of choice for 3 to 6 months, and alternate therapy with potassium iodide consisting of 4 drops of potassium iodide in water or juice thrice a day for 1 to 6 months is another alternate therapy. Whereas disseminated infection requires administration of amphotericin B intravenous followed by an oral itraconazole for a duration of 12 months. Other alternatives like terbinafine and posaconazole also can be used. However, we must remember fluconazole, voriconazole, and ketoconazole are inactive to this fungi in vitro, hence this should be avoided as a therapy. Coming to my fourth case, so this is a case of a 36-year-old IT professional who was a manager in southern part of India. He had been having since 2014 multiple cervical lymph node enlargement, and has been also after subsequent years has been having hip pain with discharging sinus in and around the hip joint. So with these complaints, he has visited multiple doctors, multiple biopsies were done which revealed granulomatous inflammation, and he was started on multiple courses of antitubercular therapy till in 2018 he presented to CMC, and he presented to the orthopedic department because he had a severe right hip joint pain, and on investigations his MRI was done which showed osteomyelitis and extensive involvement of the right hip joint with involvement of sacroiliac joint and osteomyelitis of the right hemipelvic bones. It also showed multiple sinus tracts communicating with the rectum and the anal canal and forming perianal fistula with extension into the left pelvic side wall. So he was managed by the orthopedics, and they went ahead with a debridement of the right hip joint with an arthrotomy, and then infectious disease consultation was sent. The biopsy done from the operative site revealed a chronic inflammatory process. So, as you know, infectious disease physicians are known to take a detailed history even to the extent of annoying the patient and their relatives at times. So we went into the details of the history, and we found a very significant travel history in him. He had visited the US between 2010 and 2012, and these are the places that he had visited for during this visit to the US. He also had an exposure to sandstorm while he was in Arizona. So then we had a discussion with our microbiology team and our pathology team, and then we tried to make a diagnosis, and the pathologists were able to find a thick-walled spirue of fungus, which is measuring 20 to 30 microns, containing many endospores ranging from 3 to 5 microns in size. And then finally, the culture grew filamentous fungi, which was identified as Coccidio Domicosis. So let us see something about Coccidio Domicosis. So it is also called valley fever or desert rheumatism, and the recent travel to these areas are critical for diagnosis. Infection is virtually always acquired through inhalation route, and sometimes the primary infection goes unrecognized. However, it is picked up when the patient has disseminated infection like this gentleman had. And then for our patient, since he had an osteoarticular involvement, he was started on amphotericin B for 2 to 4 weeks, subsequently followed by fluconazole. It was given to our patient, but an alternative itraconazole also can be tried, and he also underwent a surgical debridement of the sinuses which were formed. Coming to my last case, this is a 17-year-old man who presents with recurrent skin lesions on and off for 8 years. He's been on itraconazole for a couple of years when he presented to us, and he presented with erythematous, fleshy nodules and plaques on his earlobes, cheek, upper and lower limbs. It was also associated with lymph node enlargement. And this is the picture of his lesion. So it was present in the legs, it was present in the back, which was extensively seen, and so the active lesion from the arm was biopsied, and this is what it revealed. So it revealed in the microbiological department, it grew Phyllophora oxyspora, and so a diagnosis of chromoblastomycosis was made. It is also called as pigmented fungi or demataceous fungi. It is a chronic, indolent, granulomatous fungal disease. The route of infection is mainly by inoculation, usually occurs in tropical and subtropical climates, and cutaneous trauma remains the risk factor for acquiring this disease. The treatment for this disease can be challenging. It needs a surgical excision, and in itraconazole is the drug of choice in the dosage of 200 to 400 milligram per day, and an alternative dose with terbinafine can be tried. And there is high failure rates and recurrence rates, which are very high in these infections. And subsequently, even some combination therapy can be considered for these infections. So that brings me to my concluding slide. Endemic mycosis require a high degree of clinical suspicion. A clue to the diagnosis lies in the epidemiological and travel history. Host immunity plays a very important role in these infections. There is a huge morbidity. Tissue culture and histopathological evidence is of utmost importance in making the diagnosis. And serological diagnosis, when they are used for diagnosis, cross-reactivity has to be kept in mind. Amphotericin B forms the drug of choice, especially in cases which are moderate to severe disease, or there is an involvement of CNS or bone in the induction phase, and the consolidation phase can be treated with either itraconazole or voriconazole. Oral posaconazole is a good alternative and a newer therapy which can be seen. While using the azoles, we need to be very cautious regarding the drug absorption. So we tend to suggest to our patients to take these medications with either a fizzy drink or a lemon juice to have an acidic pH for good absorption, and avoidance of proton pump inhibitor is very important recommendation that we have to give to these patients. And definitely drug-drug interaction is also important for when we are choosing this patient. A therapeutic drug monitoring can be done in patients, which can tell us the drug levels, and more so, which will tell us the toxic levels or the toxicity to these patients. And I would like to acknowledge some people from my department. Thank you so much for your patient listening.
Thank you, Dr. Divya, for such interesting cases that you came up with for endemic mycosis. It was really very informative. And here there are two questions. So one is from anonymous attendee, is written here. What is the probability of having negative serum and urine biomarkers for histoplasmosis in a patient with disseminated histoplasmosis?
So the urine assay that we are doing for antigen-based assay for histoplasmosis is still under evaluation, and we need to predict whether there are some drugs that have been taken and other lab abnormalities that can be seen either because of contamination of the sample or in many areas. And even most of these patients, they come up with either partially treated. So that is also one of the reasons for seeing a negative result. And also we have to remember that these antigen-based assays, as Dr. Aruna Loke had pointed out very clearly, that this lateral flow assay or the antigen-based assay can have a lot of times can be negative. So these are some of the reasons that we see that they are negative. They may be negative.
Okay, thank you. Now the second question is from Dr. Ajit Thomas. He is saying it's of course a good case of histoplasmosis. However, the huge adrenal glands should have directed the diagnosis away from TB for the original treating team. One, then what was the cause of the lower limb weakness?
So he had a significant weight loss, and there was no cause as such which was found out. He had a significant weight loss, and it was, in my case presentation, I did not suggest that he had lower limb weakness. It was an significant weight loss that the patient presented with, which was his general debilitated state it was.
Okay. And maybe in these patients, when you have adrenal tuberculosis, hypotension, electrolyte imbalance, low potassium, sodium, were they done? And that will also help, in addition to simply saying that, okay, it could be because of the extreme weakness, weight loss, it's tuberculosis.
Yes, of course. So the presentation depends on we had a culture which was proven for these patients, and we had done all the other. Whenever we do a biopsy from the adrenal gland or the bone marrow or a trephine biopsy, we always send for expert and midget culture. I did not put it into my slide, but they were all negative for this patient.
And this one last and interesting question from.
Thank you, Dr. Divya.
Thank you, sir.
Ma'am, sir wants to ask about Emergomyces pasturina in India, which is increasing as a dimorphic fungi. So your experience with it and...
So I have not really seen a case till now. I'm sorry, I won't be able to comment on it, but I'm sure there will be some anecdotal reports which are there in India. I haven't really looked into it.
I think this Emergomyces pasturina, both of the cases which we have diagnosed, this is becoming important. It's so difficult sometimes to distinguish from histoplasmosis. That's why I always say that only if you do diagnose on the basis of histopathology, you may miss this Emergomyces, because Emergomyces had come up in South Africa, but we had not seen the Emergomyces africanus. We are seeing in India Emergomyces pasturina. That is a more commonly seen in Italy. Thank you.
Yes, sir. Thank you. Yes, sir. Definitely, we had cultured this and it was isolated, but yes, your point is very well taken, sir. Thank you so much.
Hi, this is Dr. Chandra. Dr. Diodar, may I ask you a question?
Yes, sir. Yes, sir.
Thank you so much for the nice presentation. Endemic mycosis like blastomycosis or Coccidio Domicosis, how often do you see that in various parts of India? Are they seen at all? I know histo is fairly common. What about others? And the second question I would like to ask is chromoblastomycosis. How much is it missed? I'm sure it's very prevalent in many, many hospitals and seen. Many physicians are probably unaware how to make a diagnosis. How, in your opinion, as a tertiary care hospital person, how often is this diagnosis missed? How long does it take for these diagnoses to be made accurately?
So to start with your first question, so blastomycosis, not really seen in Indian subcontinent. This patient which I presented of Coccidio Domicosis also we were able to diagnose after he had gone to multiple hospitals. So since the epidemiological or India is not an endemic country, so definitely the Indian physicians are not aware of these fungi, and that is the reason that they are missed. Even when we went and saw this patient of Coccidio Domicosis, we took a little time to diagnose, and then we were all very excited when we could make a diagnosis, because this was the maybe just 2-3 cases, I think, and it is probably referral bias that we had seen this patient as such. And coming to chromoblastomycosis, we have had a couple of series presented from CMC, which are published, and also I think it was put up as an abstract in the previous 2 ID week conferences. So we see quite a number of pigmented fungi which are isolated. I know the problem lies we are not able to speciate them, and sometimes when there is a poor clinical suspicion or we don't suspect them in patients, then usually it is missed if we do not have. Just one important comment I would like to make is that interdisciplinary team or a multidisciplinary team is very important in diagnosis, in making a diagnosis of endemic mycosis. So an expert ID team with a microbiological lab backup and a pathological lab backup is very, very important.
I think, thank you. I must, because we are, I think, running short of time. It's already exceeding the time. So thank you, Dr. Divya, for such a nice presentation and answering the questions. Now, we go on to the next topic. It's from Dr. Mayur Ramesh, who is directly connecting from Detroit, USA. We will be talking on pre-transplant workup and considerations of lung transplant. Please, Dr. Ramesh, go ahead.
Thank you, Dr. Gupta, and thank you to the organizers. All right, and good morning to my mentor, Dr. Chandra, and good evening to all the Indian colleagues. My talk is on pre-transplant infectious disease workup, predominantly focused on lung transplant, but generally it holds good for all the solid organ transplants as well. I have no conflict of interest. So objectives, we are going to talk about some pre-transplant screening related to history, physical exam, and lab testing. Talking about some cases related to screening for donor-derived infections, a brief word on pre-transplant vaccinations, and of course, we cannot have a talk like this without talking about COVID screening and vaccination in SOT, and a summary slide. So what are the principles of pre-transplant screening? It is to assess risk of relevant infection in the transplant recipient, and this manages the acceptability of the risk versus the urgency of transplantation, and also to help mitigate the risk of infection in the recipients with any available prophylaxis and vaccination. So when it comes to pre-transplant screening in recipient, to determine immune status of a recipient against common transplant infections, this may be useful, such as things like CMV or toxoplasma, or you can allocate appropriate organs to already known carriers of, for example, recipients who have hepatitis C or HIV, or you can recognize and treat latent infections, which will be reactivated post-immune suppression, such as TB, endemic mycosis, or you can avoid transplantation in a patient with poor prognosis, such as MDR pathogens. For example, in lung transplants, you want to be extra careful if there's baseline colonization with organisms such as B. cepacia or Mycobacterium abscessus. So generally in recipients, we do extensive history for prior infections, vaccinations, unusual exposure based on where they reside, where they have traveled, if they reside in an endemic area, if there is prior history of any drug use, including IV drug use, risky sexual behavior, incarceration, if they have any pets, occupation, hobbies, if they have drug allergies, particularly antibiotic allergies. And then we also do a thorough examination. During the skin exam, we particularly also additionally look for warts in perineal regions. For example, the rationale being post-transplant, the warts become very aggressive. And in one patient, we ended up losing the graft just to help treat the wart because it was so aggressive. So it's things like that are important. And the potential transplant infections can come in the form of syndromes from the donor. For example, the donor can have encephalitis syndrome or a pneumonia or multi-organ failure with sepsis, and can have different bloodstream infections, bacterial meningitis, pneumonia, tuberculosis, syphilis, various fungal infections, including endemic mycosis, candidemias, various viral infections, including HIV, hepatitis, viruses, influenza, and of course now SARS-CoV-2 and several other viruses, and certain parasitic illnesses such as toxo, strongy, trypanosoma, leishmania, etc. So in the United States, in 2005, the OPTN policy requires reporting of all potential unanticipated transmission events. So they set up a disease transmission advisory committee, and they review and classify proven versus probable donor-derived disease transmission events. So in some of the data that was published recently from 2012 to 2017, I'm focusing more on lung here. All you can see, for example, in viral infection, when it comes to lung, community respiratory viruses, when that is present in the donor, it's almost guaranteed you're going to get it in the recipient. Similarly, in bacteria, mycoplasma, if it is present in the donor, almost guaranteed you're going to get it in the recipient. So, and if you look at lungs compared to other transplant, there is definitely much more higher chance of transmission of various different pathogens that are present in the donor. That includes additionally mycobacterial diseases and parasitic diseases as well. Other potential transmissible diseases include CJD, which we won't talk about in this talk, or malignancy can be transmitted as well. Hematologic malignancies, melanoma, certain inborn errors of metabolism have been transmitted, and drug and food allergies have been transmitted as well. Generally, when you screen for all organs, particularly diseased donors, they do recommend checking blood and urine cultures as a baseline, HIV serologies, hepatitis B serologies. We'll talk about NAT testing in a little bit more detail. Hepatitis C serology and hepatitis C NAT testing, syphilis testing, and EBV serology, toxoplasma in hearts, and respiratory cultures, particularly in a lung donor. And if you have endemic risk-based testing, includes West Nile, cocci, particularly from southwestern United States, strongylitis, trypanosoma, and latent TB testing. What about recipients? Similarly, you do check for hepatitis, HIV, and hepatitis C serologies, syphilis testing, CMV, EBV, VZV serologies, toxoplasma in heart, TB screening, and endemic risk-based screening as well. Now we know that in both deceased donors and living donors, when it comes to HIV, hepatitis B, and hepatitis C, there is a rationale for doing NAT testing, and we'll talk in more detail in the next slides. And I'm sorry, the slide is a little bit smaller, but what I'm trying to say from this slide is based on your serology between donor and recipient, you also make some recommendations. For example, if a HIV donor is positive and recipient is negative, certainly we're going to reject that donor, particularly these are disease donors. Whereas in hepatitis C, nowadays, since we have excellent treatment, you're not going to reject mismatched donor positive, recipient negative hepatitis C. Whereas in hepatitis B, we cannot achieve a cure. So at this point, the general recommendation is if the donor has active hepatitis B, such as the E antigen being positive or the DNA being positive, then the recommendation or occasionally in a setting where there's a strong suspicion of hepatitis B in the donor, the recommendation is you want to be careful and you want to avoid that organ. So let's start with a case. A fever in a recent liver transplant and lung recipients. The potential donor was a male with injection drug use, MRSA bacteremia, endocarditis, septic emboli to the brain, and on greater than 48 days of antibiotic therapy. And he was culture-free. Culture was negative at the time of organ procurement. The recipient 1 was an end-stage pulmonary fibrosis in ICU, critically ill, and the recipient 2 was end-stage liver disease patient, which we took in Henry Ford Hospital. So can we use organs from this donor? So let's see what happened. So particularly in our liver recipient, the CDC matched MRSA from the valve tissue from the donor to the recipient. And the gel electrophoresis matched MRSA isolates from all 3 episodes of bacteremia in our liver recipient. So the liver recipient ended up having recurrent bacteremia. Similarly, the lung, which was done in a sister hospital, the lung recipient had recurrent MRSA bacteremia. So the 4 other transplants were done, including the lungs, liver, kidney, and pancreas. The kidney and pancreas people did not develop any MRSA infection. All recipients were given MRSA post-op prophylaxis. Only the liver and lung recipient developed recurrent MRSA. Currently, all recipients are doing well. So what can we learn from this? So approximately 5% of donors have bacteremia at the time of procurement. Bacteremic donors, generally the outcome is very good. And donor and recipients are generally treated before a transplant. And there is particularly if the organism is a non-MDR organism, the prognosis is actually good. What about endocarditis in donors? You want to exercise caution because there can be septic emboli, particularly in large organs such as liver or lungs. So in bloodstream infection, there have been reports of Staph aureus, Pseudomonas, and bacteremic donors can be usually provided with appropriate antimicrobial therapy. And we want to make sure that they responded to therapy and the cultures are cleared before we take the organs. And in bacteremia or candidemia, in the recipient, the recommendation now is to treat at least 14 days with appropriate systemic antimicrobial therapy. When it comes to Staph aureus, Pseudomonas, sometimes you need to give a longer duration of therapy, particularly as illustrated in our patient. What about the non-bacteremic localized infection in donors? We generally may consider treating urine cultures in kidney donors, particularly early in the transplant, or positive respiratory culture in a lung donor, particularly if the donor had symptoms. What about bacterial meningitis in the donor? If the donor has received at least 24 hours or greater antibiotics and therapy is continued in the recipient, as long as it's a treatable meningitis, the donors are still considered suitable. Next case is a fever with lung infiltrates 4 months after liver transplant. So in the donor, we were called a few days after the transplant was done that the splenic biopsy had organisms suggestive of histoplasma. So the recipient was initiated on treatment with itraconazole, but unfortunately continued after a few days because of side effects and did not inform us. And a few weeks later, he ended up developing pulmonary and systemic histoplasmosis. So what about fungal infections in donors? Routine donor screening for histoplasma from an endemic area is not generally warranted, but if the explanted organ has granuloma, we want to check for fungal cultures and look for antigens and antibodies to histoplasma and then intervene in the recipient appropriately. What about if there is calcified pulmonary hilar or splenic granuloma? If it's completely calcified, generally it's not a contraindication to donation, but you want to be being extra careful trying to look for cultures, antigen, antibodies in such a case. In coccidioides screening generally is needed for living donors from endemic areas. What about Cryptococcus? If there is somebody with meningoencephalitis of unknown etiology, you would generally recommend in that donor to have cryptococcal serology as well, or pulmonary nodules, or if the patient is immunocompromised, particularly a lot of steroid use. The third case is a healthy man with nausea, paresthesia, emesis after fishing, and he had fever, seizures, dysphagia in the emergency room. The LP had 9 WBC, had negative studies for HSV, VZV, CMV, HIV, Cryptococcus. MRI did not have any abnormalities, and the patient, the donor was brain dead after 17 days in the hospital. And the presumed diagnosis was ciguatera toxin poisoning. And the question was, can we use this donor? Remember, this is an unknown encephalitis. There was no proven diagnosis yet. And this was eventually published in JAMA. This turned out to be rabies. There was a delayed presentation, and the recipients also developed rabies and eventually died. So there are some unusual transplant-transmitted encephalitis clusters of S. Nile, LCMV, rabies, Balamutia, and you can see that half the recipients are dead when you have things like this. So if you want to be extra careful in assessing for them and trying to probably say no to those donors. So in potential CNS infections, if there is a cerebrovascular accident with patient have no known risk factors, or if patient presents with fever, encephalopathy without a diagnosis, or with seizures without a diagnosis, or CNS or cerebrospinal fluid abnormalities that doesn't have an obvious infectious etiology, or if there is a proposed, say, environmental exposure or risk factors, you want to be extra careful about trying to see if you can say no to such a donation. So let's talk briefly about the increased risk donor, HIV, hepatitis C, hepatitis B. So a 25-year-old with motor vehicle accident and is brain injured, he has history of IV drug use. He's seronegative for hepatitis H and hepatitis serology B and C. What is the actual risk of transmission of these viruses to the recipient? And does the negative NAT testing in the donor make the decision for using the organs easier? So as you very well know, in all of these viruses, after the exposure, there's a small eclipse period followed by viremia. And then after several days is when the seroconversion happens. So clearly, you can see in all these viruses, hepatitis, HIV, hepatitis C or B, compared to enhanced serology, nucleic acid testing clearly reduces, can catch these diseases much early. So, and that is true for all types of donors, including men who are sex with men, injection drug users, commercial sex workers, hemophilia, blood product exposure, incarceration. And if you look at HIV versus serology, clearly NAT reduces the window period. So based on this, these are the high-risk people, including people who have sex with suspected viral diseases, MSM, commercial sex workers, IV drug users, incarceration, persons with prior sexually transmitted infection. Additionally, if you're on hemodialysis for the past 12 months, you might want to check for hepatitis C additionally. In pediatrics, if a child is less than 18 months and the mother at risk for viruses like HIV, hepatitis B or serology, or the child is breastfed in the last 12 months and the mother at risk. Sometimes in hemodilated screening specimens, what happens is that your serologic testing may be not good. And if donor history is not available, in those conditions, you want to consider, you want to put them as an increased risk donor, and you have to do certain things. And that includes, for the donor, you want to check both NAT serology immediately pre-transplant, and the living donor at least less than 20 days pre-transplant. In the recipient, we check the serology and NAT testing, immediate pre-transplant, 1 to 3 months, and then eventually 12 months. for hepatitis B. So in special circumstances, we talked about bacteria for MDR organisms, particularly lung transplants, fungal if there's endemic areas like Cocci, West Nile history or HTLV serology if there's risk factors, or parasitic based on where endemic areas and stuff, serologic testing to be done. And what are the consideration? Clearly, if the infection is identified and there is effective treatment, particularly, for example, pneumococcal meningitis, it's okay to use those organs. What about MDR organism? Poor treatment with toxicity, and it's going to impede with transplant, then definitely caution is recommended. What about if the donor is particularly very sick? Then you're probably going to get very marginal organs, and that might be seeded and maybe having complication post-transplant. So you may want to consider not taking such a donation. And clearly, if there's an infection of unknown etiology, particularly if there's encephalitis, you do not want to use such donation. Brief word about syphilis. Nowadays, we do a reverse testing algorithm for donor and recipients. We do the EIA for IgM, IgG serology for treponema, followed by RPR, and then, as needed, treponema-specific serology, particularly TPPA. And the transmission of syphilis in SOT is rare. Positive donor serology is not a contraindication because you have excellent treatment to treat latent syphilis. Generally, it's benzidine penicillin 2.4 million units for 3 weekly doses. What about MTB? Donor-transmitted TB accounts for about 4% of post-SOT TB. Active TB in donor is not a contraindication to donation. Live donors should be screened for TB. And screening is generally nowadays is done by IGRA or the TB quantiferon assay. If positive TB, if this is positive, you want to make sure there's not active TB in the donor, and particularly live donor. Recipients of organs from donors with latent TB should be considered for treatment for latent TB as well, even after transplant. What about strongy? In tropical, subtropical regions, seropositivity may be as high as 80%. In the United States, it's lower. It's 4% seropositivity in the Appalachia and Southeastern United States. So screening donors from endemic region can be done, and treating recipients of seropositive donors with ivermectin. I believe in certain transplants like liver in certain centers in India, routine pre-transplant ivermectin for recipient is being done. What about vaccination? In the living donor, current and routine recommended vaccines are suggested based on age, exposure, and prior vaccine history according to a CDC schedule. Live vaccination should be avoided within 4 weeks of organ harvest. What about recipients? Generally, they want live vaccines to be given at least 4 weeks prior, and inactivated vaccines at least 2 weeks prior. And so it's pretty much similar to the donor. General pre-transplant vaccinations are the pneumococcal vaccination 13 and PPSP 23, hepatitis B, hepatitis A, particularly liver, Tdap, influenza, which is seasonal. And nowadays we do talk about COVID vaccines, which we'll talk briefly. And then zoster vaccine, now we have Shingrix, which is a component vaccine, and hepatitis and HPV. It's predominantly, we recommend the HPV vaccine being live to do it pre-transplant. And generally, live vaccines are given pre-transplants and compared to post-transplant. And some of the vaccines, such as hepatitis A or B, and certain other like MMR, we do check for serological response to see if the vaccine, if there was vaccine uptake. What about travel vaccines? Similarly, depending on where you're going, live vaccines are given before transplant and cannot be administered after transplant. What about COVID-19? Surprisingly, not surprisingly, lung transplant is at higher risk for COVID-19 from an infected donor. And to date, approximately 4 cases of deceased donor lungs were initially tested negative from the upper respiratory sample, were eventually tested positive with the lower respiratory tract sample. So proven or probable transmission occurred in 3 of them, and of which 1 of them died, and that's in University of Michigan, which was published because there was a delay in diagnosis. In the 4th case, the lungs were discarded based on lower respiratory samples. So nowadays, the recommendation is to actually get both upper and lower respiratory sample, particularly in lung transplants. And you want at least 72 hours before you want to get that sample. In the non-lung recipients from the same 4 donors, nothing happened in any of the recipients with signs of COVID symptoms. So this is still a moving target. We are still learning more, and I'm sure with more experience, there'll be better recommendations as we go along. So generally, we want to test donors within 72 hours of organ procurement. With lungs, as I suggested, you get both upper and lower respiratory tract. So you want additionally, if you have known prior, for donors with known prior COVID, you want a negative PCR from respiratory tract, including lower respiratory tract and lung donors. Symptoms should have been completely resolved, and at least minimum 21 days should have transpired since the date of onset. If that original donor was immunocompromised, then this rule might go out of the window. So you might want to be careful. So at the end of the day, you definitely want to use your local ID experts when it comes to this. What about vaccination? All solid organ recipients should be vaccinated against SARS-CoV-2 using locally approved vaccines. And all eligible household and close contacts of those recipients should be vaccinated to minimize risk to the recipient. And whenever possible, with newer information, vaccination should occur prior to transplantation. And you should wait at least 2 weeks. It should be at least 2 weeks prior to transplantation. And with the newer information in the United States, we've started giving a 3rd dose of mRNA vaccine for the SO2 recipients who have previously completed 2 doses of mRNA vaccine at least 28 days ahead. And this may change from country to country. But at the end of the day, we cannot assume that the solid organ transplant recipients are going to mount a good response. So they have to behave like unvaccinated people by masking in public spaces, social distancing, frequent hand washing, and avoiding unnecessary crowds until this pandemic gets over. So in summary, need a thorough history and examination. With increased risk donors, NAT testing definitely reduces the window and reduces the risk. In bacteremic donors, you want to use caution when there's high-grade bacteremia or endocarditis, and because there may be seeding of the transplant organs, particularly large organs, such as lung and liver. If there is donor of encephalitis of unknown cause, please avoid and complete vaccination pre-transplant as much as possible, including the COVID-19 vaccination. Thank you.
Thank you, sir, for such a comprehensive talk covering everything from unknown and challenging cases to vaccination and guidelines. I don't think we have any questions in the chat box. So we move ahead. So thank you again for such a beautiful talk. And we move on to the next topic, which is challenging cases in immunocompromised patients, which will be moderated by Dr. Nitin Sood. So fasten your seatbelts for a challenging session ahead, and over to Dr. Nitin Sood.
Yes, thank you. Thank you for handing over the mic to me. So I'm Dr. Sood, and thank you to the organizing committee for inviting me to moderate this session. As a practicing hematologist, I'm very acutely aware of the importance of infections and the inputs from our infectious diseases team that we get from time to time to deal with bloodstream infections, catheter-related infections, all sorts of infections that we have to deal, especially gram-negative infections, which are our main problem in induction, and the mortality is very high in such situations. We cannot also overlook the importance of prophylaxis in our patients, because that is something that gets us or keeps us away from trouble. So let's hear from Dr. Chandrasekhar about infections in oncology and hematology patients. Welcome, Dr. Chandrasekhar.
Good morning. Good morning, everyone. Good evening. I thought my talk was going to be after the case discussions. I didn't realize it's right now. Okay, we'll get it started. So the topic Neha asked me to talk about was infections after stem cell transplantation. Many of you are quite familiar that the stem cell transplant patients are at very high risk for infections, a variety of different infections during the transplant. And if they happen to develop complications such as graft versus host disease, then because of the continued immunosuppression, they're at risk for a variety of different bacterial, fungal, mycobacterial, opportunistic pathogens, right? We are all aware of that. What if the patient doesn't develop graft versus host disease? What kind of problems may they run into? How careful should they be? I think these patients are always concerned. Am I always at risk? Next slide, please. Okay, so this is an excellent slide. This was published over 10 years ago. You can see how long it takes for immune reconstitution to occur in terms of the neutrophils, the B cells, and the T cells, and the plasma cells. You can see there is a gradual return of a variety of cells over a period of months, frequently years, pointing out the fact that these patients are compromised for a long, long period of time. And in my opinion, even after complete engraftment, complete reconstitution, there may be unknown factors that will put them at risk for ongoing immunosuppression at some level. So frequently we see patients 10 years later coming in with an obscure infection, okay? So this is a never-ending process, in my opinion, in terms of complete immune reconstitution of the stem cell transplant recipient. Next slide, please. What determines a patient risk for infection? You could see that underlying disease, the type of the transplant, the preparative regimen, whether it's a cord, whether it's HLA mismatched, T-cell depleted, relatedness of the donor, autologous versus allogeneic. We're all fully aware the allogeneic patients are at a much higher risk, and other conditions, the time from transplant, whether it's a recent transplant or transplant was done a long time ago, so there has been ample time for reconstitution. Underlying lung disease, and as I mentioned, prolonged immunosuppression from the presence or onset of graft versus host disease. So as an ID doc, you need to keep all these in mind as you approach the patient with fever, let's say 7 years after transplant. Next slide, please. So this is a slide most of you are very, very familiar, the types of infections that a transplant patient, a stem cell patient, may be at risk for during different time periods of transplant. The first vertical column is before engraftment. Okay, neutropenia, mucositis, central venous access, where bacterial pathogens and herpes simplex are very common. Fungal pathogens are much less frequent in this setting. However, after engraftment between day 30 and day 100, with or without graft versus host disease, viral infections and fungal infections begin to play a role. Certainly, if there is GVHD, if there is ongoing immune suppression, opportunistic infections become far more common. And then after day 100, encapsulated bacteria, shingles, and opportunistic fungi once again begin to play a role. And these are higher frequency if there is ongoing severe immune suppression. So we're all very familiar with this, okay? So it's a gradual immune reconstitution after transplantation. Next slide, please. So the patients will ask me, my counts are normal, I have reconstituted. Do I still have to worry? The answer is yes, to some degree. I mean, because of what I just said, the immune reconstitution is complex. The immune system has to be turned on, and then it has to be modulated in order to distinguish a foreign antigen versus a self-antigen. And then the immune system should be turned down, should be regulated. Otherwise, unregulated immune system may create chaos. It's like a baby having a tantrum, okay? So there are many different branches of the immune system need to develop in an uneven manner. It's not a regulated, even manner reconstitution. In another linear process, it could be tissue-specific or many, many times pathogen-specific immune return, okay? So we need to convey this to our patients to say, you are at risk for a long period of time, despite abnormal counts. Next slide, please. This is, I mentioned earlier, this is a very special situation, unique in the allogeneic stem cell transplant setting. Here they are on multiple immune suppressive drugs, in addition to the fact that they have just been through a transplantation. Frequently, we give them lots of prophylactic antibiotics, vaccines, and so on, but continued vigilance is absolutely critical. Next slide, please. Okay, what about risk of infection from home and hobbies? Or we advise them to avoid anything that will produce aerosolization, such as tearing out walls, outdoor structures, move out if necessary. So we just recently saw Bordetella bronchoseptica from after patients who have been cleaning out their garage and they end up with this infection. So these are very common unless the patients are adequately warned. Wearing mask is important when they're carrying on these kind of activities. Next slide, please. Infection from food. Most of us, being ID physicians, are very familiar with the different kinds of organisms associated with certain types of food. So it is best to avoid these foods, if at all possible, post-transplantation. Oysters with Vibrio, toxo with different kinds of meat, unpasteurized foods such as cheeses, washing the fruits and vegetables are very important. These may seem like trivial matters until you see a patient who has come down with a life-threatening illness. So very, very often the patients come and tell me, nobody ever told me these things. So it's very important to take some time post-transplantation to sit down and counsel these patients as to what should be done and what should be avoided. Next slide, please. Cats and kittens. This is a big question in the United States. Could we have pets? Answer is yes, you could have pets. You know, it's not like pets are completely contraindicated post-transplantation, but one has to be using caution. Here are cats and kittens can transmit, as we all know, Bartonella, Pasteurella, Toxoplasma. These are common infections that one need to be careful when you're having a cat or a kitten. Especially children post-transplantation, frequently they come down with Bartonella after being in contact with a kitten. So these are very important points. Next slide. Dogs. Dogs can transmit infections too. Capnocytophaga, MRSA, Salmonella, Campylobacter giardia, particularly young puppies with loose stools or diarrhea. So these needs to be kept in mind when you're asking for a good history in a transplant patient who comes down with, let's say, a gastrointestinal symptom. Next slide, please. Birds too. Psittacosis is a common problem, not very common. I'm not sure how common this is in India. I bet it is probably seen frequently, but rarely diagnosed. It's fairly difficult to confirm the diagnosis of psittacosis because of lack of good tests other than serology. Again, parrots are not contraindicated if somebody wants to use them. They could keep them, but provided all the precautions are taken. Next slide, please. What about respiratory viruses? This is a very common issue, particularly with the coronavirus now. Influenza, RSV, metapneumo, adeno, parainfluenza. With the seasons, this becomes a huge issue. And as you all know, you can see here in the pictorial, atomization can lead to airborne transmission or droplet transmission. Droplets being heavy, they can infect the fomites, and therefore they could lead to contact transmission. So one needs to be careful about contact transmission as well if the organism is transmitted through droplets. If they are aerosolized, then of course it's airborne. It lingers in the air for long periods of time, and it can be inhaled by the person who is exposed, and they can acquire the virus or the pathogen. And once they have acquired it, and then of course, within a short period of time, they would develop symptoms as well. And this is very pertinent today with the COVID pandemic. Next slide, please. So I would like to talk about COVID a little bit in the transplant setting. So we, at this point in stem cell transplant patients with COVID-19, we promptly administer the monoclonal antibodies, Casirivimab and Imdevimab. We don't, there's no delay. We don't wait for symptoms to get worse. As soon as possible, the patients are administered the monoclonal antibodies because, as you all know, The sooner you give the antibodies, better is the outcome. And we do not have a major threshold for giving remdesivir. We avoid dexamethasone whenever possible, unless the patient is symptomatic and needs oxygen supplementation as the routine indication. And we carefully assess them for any secondary infection. And in terms of vaccination of autologous and allogeneic patients, generally, as the American Society of Transplantation recommendations go, we give them the vaccination around the 3rd month after transplantation in those patients who have not had COVID-19. However, as I mentioned, the major take-home point is if they do have diagnosis of COVID-19, we try to promptly give them the antibodies as quickly as possible. Next slide, please. So I'm going to share a case example of a patient who has undergone a CAR T transplant, chimeric antigen receptor therapy. And this is not a typical allogeneic transplant, but it's somewhat analogous to an autologous transplant. So what happens to a patient who acquires COVID-19 in the immunocompromised setting? This patient presents, 47-year-old guy with cough and shortness of breath, diagnosed in April of this year, day 0, admitted to another hospital, treated with steroids, conventional, discharged without significant improvement of symptoms. Okay, since discharge, now he's coming to our facility, more fatigued, persistent cough, shortness of breath, dizzy when standing up, presented on day 38 after the original infection. A month has gone by, he continues to be symptomatic. Next slide. Past history would tell us he was diagnosed with a non-Hodgkin's lymphoma in 2018, has been heavily pre-treated with all kinds of chemotherapy drugs. And on May 6th, he undergoes a CAR T procedure. Preparative regimen was fludarabine and cytoxan, cyclophosphamide, and develops a cytokine release syndrome, grade 2, went on to receive tocilizumab, again, remains persistently febrile, okay? And in May, he develops, he gets dexamethasone, develops mental status changes, and DC'd in May 20. Next slide, please. And labs on presentation now, he continues to be symptomatic after a month or month and a half of COVID-19 in the post-CAR T transplant setting. Okay, remember, the CAR T was performed in 2019, 2 years earlier. 2 years later, now he comes in with the COVID-19. His white count is 1,000. His lymphocyte count is 100. A hemoglobin of 8, platelets of 60, creatinine 1.3, and the COVID PCR is positive with a cycle threshold value of 29, suggestive of a fairly high viral load. And he has no antibodies for his SARS-CoV, despite being a month after the infection. So essentially, he remains SARS-CoV-2 positive after a month of infection, despite all the treatment that he has received. Next slide, please. Next slide. Okay, you can see the CT scan, pretty typical. Nobody would deny the diagnosis, very compatible. Next slide. So this is a timeline of the problems that he has had. CAR T was performed 2 years ago. Day 0, sometime in April, is COVID PCR positive. Day 20 is at another facility. Day 38, he's been treated with steroids. Day 42, he receives convalescent plasma. Day 44, he's discharged. Day 52, he's readmitted and he's given steroids again and a second convalescent plasma. Day 60, he gets the monoclonal antibodies. And finally, day 63, post 2 months after the infection, he's discharged with taper of steroids, and recent follow-up, he's doing fairly well. So these patients have persistent COVID. Okay, so the main message is they do not develop antibodies, and they continue to shed the virus, and very frequently, despite all the treatment, they continue to be symptomatic, or what we call the long COVID problems. And this is a problem, particularly with the CAR T patients, because they receive very lymphodepleting regimens, and their reconstitution takes a long, long time. So this applies to many of our allergenic patients, and this is a huge problem. Next slide, please. So the paper was published in CID. You can see here, patient develops prolonged SARS-CoV-2 after CAR T therapy. It's a very instructive case. Next slide. You can see the timeline here. I'm not sure if you can read the entire slide. Essentially, there is persistent PCR positivity in this patient who had received CAR T therapy. And then eventually when they do, if you read the bottom line there, day 72, patient goes on to die on day 74. 72, they do endotracheal aspirate. His viral quantity is astronomically high as 6 billion or 7 billion copies. And most importantly, next slide, you can see there are multiple variants developing intra-host. Within the host, as the patient continues to shed the virus during that 2 or 3 month period, they continue to evolve. The virus continues to mutate. And this is a home bed for us to develop resistant mutants, such as the Delta variant. Okay, so our immunocompromised hosts, particularly CAR T recipients and other severely immunocompromised hosts with B cell deficiency that are incapable of producing antibodies, will shed the virus, will promote resistant mutants emerging during this whole process, and they will become the potential homes for originating the resistant virus leading to transmission. Okay, here is a nice example of multiple variants demonstrated within the tracheal aspirate in a patient who continues to shed the virus after CAR T therapy. Next slide, please. So the message is, in the transplant host, there is increased mortality with COVID-19. Consider monoclonal antibody outpatient early in the disease course. That is critical, irrespective of the vaccine status. And we are also giving third dose, as Ramesh mentioned, in the solid organ transplant patients. Here in the stem cell transplants as well, we have started giving a third dose with not a whole lot of substantive data. Okay, and we continue to ask them to practice masking and social distancing as if they have not been vaccinated. Next slide, please. So you can see the criteria for the third dose vaccine in immunocompromised hosts. Many of the societies in America have released recommendations. This is one such. In what type of patient would I give a booster dose in the immunocompromised setting? All solid tumor and heme malignancies, all patients solid organ transplant taking immunosuppressive therapy, all CAR T cell patients, and all stem cell transplant patients, moderately or severe primary immunodeficiencies, advanced or untreated HIV infection, active treatment with high-dose corticosteroids, and a variety of other immunosuppressive drugs. The main point is, anybody in your mind, if the patient is moderately or severely immunocompromised, don't hesitate to give the booster dose. There is more to be gained than lost. Based on that, at this point, we are being fairly liberal in giving the third dose with not a whole lot of data. Of course, a lot of studies are ongoing at this time, including at our center. Next slide, please. So the ASH, American Society of Hematology, has come up with the recommendations. Pre-transplant, we should be vaccinating them if it is possible, or post-transplant, we vaccinate them after 90 days of the procedure. And if there is patients who are IVIG recipients, it doesn't matter. Regardless of the IVIG timing, we would go ahead and give them the vaccine. And if there is infection developing between the two doses, then we would offer the second dose as soon as the symptoms are resolved. We don't wait for 90 days or 100 days. We would give the second dose of the vaccine right away. However, if they have received the monoclonal antibodies, then we are concerned about the vaccine efficacy. So we hold back the vaccine and give the vaccine 3 months after the monoclonal antibody exposure. These are all the ASH recommendations which we follow as well. Next slide, please. So moving on from COVID, Do we vaccinate these patients in order to prevent infections? Absolutely, yes. This is what we've been doing for the past several decades in the post-transplant setting, whether they are allo patients or auto patients. This is our vaccination regimen, as you can see, against a whole host of viruses and bacteria. And I'm sure most of the transplant centers in India also have protocols like this, not very dissimilar, and this is absolutely critical. And these undergo periodic changes. Now with the new pneumococcal vaccine, we would have to readdress and change the policy as well. Next slide, please. The other main thing, main thing is the new Shingrix vaccine or the new recombinant shingles vaccine. We have started giving them to all our autologous patients, and pretty soon we'll be starting them in our allogeneic patients as well, because the allogeneic data is still lacking with regard to the new recombinant DNA vaccine against the shingles virus. So the patient says, what should I avoid if my immune system is weak? You can see here, avoid other school children who may be ill, anybody who is ill, crowded areas, construction sites, wood burning fireplaces, you can smoke inhalation, maybe potential transmission of pathogens, air humidifiers, Legionella becomes a pathogen, and well water, swimming in lakes. In India, some of these may be difficult, crowded areas. You may have to wear a mask. How long should the patient be wearing the mask after transplant? These are difficult issues. 2 years later, should they still be wearing a mask? It's ideally yes, but it's hard to practice. So in places like India, where the crowded areas, transplant patients, they're always posing themselves at risk. Okay, to avoid it is not completely possible. Next slide, please. Vaccinating others in the household, it's absolutely critical. This we often forget, or the family members may refuse. They should be vaccinated, so they provide a ring around the patient and providing a ring vaccination effect. This is very critical, and children should receive the live vaccines. There is no contraindication if children at home, in a home where there is a transplant recipient, they can receive the live virus vaccines as well. There is no contraindication. Next slide, please. So the final summary I would like to leave with is transplant recipients are at risk for infection throughout their life. Okay, the risk never completely goes away despite absolutely normal numbers. So vaccinations are paramount importance. All the usual precautions that we talked about, the pets, the food, the water, the travel, etc. The patients can live normal lives. They're always living in fear. So it's very critical for us to encourage them to try and lead as normal a life as possible. They can have pets, they can travel, they could mingle with people, but they should use some caution as we go along and not to be overconfident that their numbers are normal, their counts are looking good, so they could do whatever they want. That is not entirely accurate. With the COVID-19, all healthcare workers in the transplant institutions must be vaccinated. This is critical. We have made it mandatory that at our cancer center, everybody should be vaccinated with this COVID-19 vaccine. Otherwise, they don't have a job at our institution. I don't know how many transplant centers in India can mandate a vaccine among their healthcare workers. This is critically important because we are taking care of very immunocompromised patients. We don't want to give them COVID-19 after they come into our institution. There must be, all healthcare workers must be immunized. All transplant recipients must be boosted with a third dose. And overall in transplant, patient families should take an active role in taking care of the patient as well by immunizing themselves and following the usual precautions. Okay, so this is a nice topic, infections after transplant, often not talked about. People take it for granted. One should not take it for granted, particularly now with the pandemic that we are living in. I have about 8 seconds left. I think I'll stop at this point. Thank you for asking me to give this talk. It's very nice to see a lot of familiar faces. Thank you. I'll stop here.
Thank you, Dr. Chandrasekhar. That was excellent, especially the little tips that you had for us. I can allow one question since you finished on time. That's we could allow one question. But while I don't think there are any questions, but while we wait for questions, can I ask you one?
Sure.
So we as transplant physicians and hemato-oncologists, we deal with a lot of immunocompromised patients. And we are very clear on antifungal and antiviral prophylaxis, which is a yes to everything. But what is your view on antibacterial prophylaxis? And I know we've gone back and forth on that one.
Yeah.
I just wanted to know your view.
Yeah, antibacterial prophylaxis in the what time period? In the pre-engraftment or in the post-engraftment?
So pre-engraftment plus antibacterial prophylaxis for leukemia induction patients, where the count is really going to be down and going to be down for a couple of weeks.
Yeah.
Especially to sort of sterilize the gut, if you like. That's the...
Oh, I see. So you're asking me about in the pre-engraftment in the neutropenic period.
Neutropenia phase, that's
correct. That's a slightly different area, what we talked about now.
Yeah.
In the neutropenic setting, in the Western world, gram-negatives are the major concern. And fortunately, most gram-negatives are susceptible to quinolones, fortunately, in the Western world. So here we use a quinolone, such as ciprofloxacin, as the main drug for prophylaxis against Pseudomonas aeruginosa, primarily during the neutropenic period, particularly in the intensive 3+7 regimen in our acute leukemics. But one must remember in the other situations, such as lymphoma patients, myeloma patients, and all solid tumor patients, we do not use antibacterial prophylaxis. So the prophylaxis is only confined to acute leukemia setting when they're receiving the 7+3 regimen. In other settings, we conserve quinolone use. There is no good data to support quinolone prophylaxis in other settings because 7+3 is so unique in producing a neutropenia as long as 1 month. Therefore, we are careful about gram-negative prophylaxis. In other settings, it has not been conclusively proven to be of benefit. I cannot say the same for India because in India, most of the damn gram-negatives are resistant to quinolones.
Yeah.
So it becomes useless exercise to give quinolones in that setting. So you are in a much more difficult situation because you do not have an effective, simple drug to use for prophylaxis during the neutropenic period to effectively protect them against multi-drug resistant gram-negative infections. I don't know if Priscilla may have some other strategy in their institution for MDR gram-negatives or commonly seen gram-negatives in the neutropenic setting.
Dr. Chandra, we actually don't routinely use prophylaxis basically because we can't. So we just are very aggressive with neutropenic fevers when they occur, but we don't routinely use prophylaxis.
I think that's a very, very important point because I know many of the Indian institutions abuse antimicrobial prophylaxis. So one needs to use common sense and say it's totally ineffective. Certainly you do not have to follow what the Western world is doing.
This is George Verghese from George Verghese.
Sorry, I'll let you.
See, this in the Indian setting, prophylaxis is as Chandra was saying, was practically useless. So quinolone prophylaxis has its own problems and promotes more and more resistance. So it probably makes sense to bite the bullet and avoid it. And treat early when you suspect something is going on, because there is no real drug for prophylaxis in our setting. And that's important to remember. We only make matters worse by...
George, unfortunately, George, most of the Indian institutions use drugs.
I'm very aware of that. I'm very aware of the realities.
Hematologists have not received the message.
My perennial battle is to try and decrease drugs, but it never works.
Yeah, I can vouch for that because we were looking at our sensitivities, and our levofloxacin is the drug that most people use, as you said. But I can say less and less hematologists are using it now because there's only less than 10% sensitivity of gram-negative organisms to I mean, at least in our area. So we were recently looking at our sensitivities, and the scary thing is that even meropenem is less and less effective against the gram-negative organism. So that's a constant struggle for us.
And prophylaxis, you don't have to rely on chemicals for prophylaxis. Good hand washing, good hygiene is more than adequate in the majority of settings. And another big area where we can conserve antibiotics is all the non-leukemic immunocompromised patients, myeloma patients, lymphoma patients, all the solid tumors, which are 4/5 of all cancers. You do not need anti-infective drugs. Unfortunately, hemato-oncologists are very fond of using these drugs.
I mean, the other organism which causes problem, which often grows out, is Enterococcus faecium. Again, a consequence of prolonged use. And that is also a very real problem.
It seems like we are preaching to the choir here.
I would add on that it's not just the stem cell which is in trouble. Even solid organ faces the same problems as well. What I can tell you is from our own data, we were looking at carba and rectal swabs for our recipients and donors. Initially, our recipients were all coming back positive. They continued to remain positive even pre-transplant, either having NDM, OXA48 or both. Now, what is even worrying is that more and more of our donors are also turning positive, which is possibly indicative of what's happening in the community. So any antibiotic use before any kind of procedure is just bad news.
I think if I want to leave a message for the hemato-oncologists and for the younger ID physicians, when you look at protocols from the West, please ask the simple question, how applicable is it to our environment? Without embracing it blindly.
That's a wonderful message. Thank you so much.
Dr. Chandra, this is Ramesh. A couple of comments in the talk. Good morning, sir. One is people who are pre-vaccinated before a transplant during their cancer phase, when they are vaccinated with COVID vaccines. The recommendation right now is actually to revaccinate them following allogenic stem cell transplant 3 months later. That's one. Second is CAR T. So I don't want people to think CAR T is the one that is causing the trouble. It is the conditioning regimen and the heavy pre-treatment that they go through prior to CAR T. That is the one that causes trouble related to CAR T. CAR T is actually an immune enhancer. So it is what is done prior to that. It's almost like an allogenic transplant. So that is the one that puts them at risk for this prolonged COVID shedding. So I just want to make those comments.
Yeah, that's a very important point. Where we use a heavily lymphodepleting. They are completely wiped out of their B cell immune function. So they are incapable of responding to the vaccine. And so when they acquire the SARS-CoV, it multiplies in the host unabated. There is absolutely nothing to prevent the virus from replicating. It's no wonder we see billions of copies weeks and weeks after the infection, continuing to be symptomatic, and they become the hotbeds for evolution of resistant variants and for spread of these variants.
Right. With that message, I think we're out of time. We'll bring this session to a close. So back to the organizers for the next one. Thank you.
Thank you, sir. Thank you for such a wonderful session. And thank you to Chandrasekhar, sir, for his rich experience and giving so important clinical pearls, and all the panelists for sharing their experiences. I hope this message percolates down to all the delegates. And if we could do that, I mean, if that message can be percolated and actually practiced, it would have a very, very long impact for all the patients out there.
Can I ask a quick question? Yes. I just thought of something. I see Ramesh and Subra and Priscilla, George, several people. How much in their cancer institutions or transplant institutions are they insisting healthcare workers should be vaccinated?
Sir, I can answer quickly. In Henry Ford, you won't have a jab come September 10th if you're not vaccinated. Simple answer.
How about the Indian setting? Mandatory vaccine for healthcare workers.
So, Chandra, we have 95% vaccination rate, and the ones who are not vaccinated just were pregnant or on some, there were some other contraindications. So it took a while to get started, but now everybody is. But unfortunately, the Delta variant, there's a lot of escape. So we are seeing, so actually our vaccine probably is not as good as the mRNA vaccines for us with the Delta variant.
But 95% is pretty good. How about Subra?
Yeah, we are at 95% as well. The problem is, at least in the private sector, turnover in the lower level is pretty fast. You know, housekeeping and people like that. So that's always a challenge. So in lower level administrative and things like that, the turnover is very fast. But we have 100% compliance in critical areas like oncology and transplant and things like that. But overall, it's at least 95%.
Dr. Sood, how about your institution?
So we don't have mandatory vaccination, but we do have, so vaccination by definition is voluntary. But again, I can say we have 95% vaccination. So only the pregnant women and, the odd person who doesn't want to get vaccinated, but they don't work in the critical areas, as they said. So transplant, we have 100% compliance.
Thank you. Thank you.
Thank you, sir. From COVID-19 virus, we move on to another challenging virus in transplant scenario, the cytomegalovirus. I invite Dr. Subramanian Swaminathan, sir, to speak on the changing landscape, prevention, and management of cytomegalovirus.
Good day, everyone. This is Dr. Subramanian Swaminathan, Director of Infectious Diseases at Gleneagles Global Hospital in Chennai and Bangalore. So over the next 20 to 25 minutes, I'm going to be talking about where we are with regards to CMV infection. And this is specifically in the dimension of organ transplant. So obviously there is more to it than just organ transplant, because we know there is some involvement of CMV even in normal hosts or slightly abnormal hosts like intensive care. But I'm going to be focusing on organ transplant. These are my disclosures. As you can see, I'm very conflicted. So let's make sure that we get some points out of the way. Remember that these are general concepts, and obviously how it applies to each person has to be understood in the situation that the patient is in. Obviously, we need to start with a risk exposure before the transplant of serologies, travel residence, vaccination, prior infections, and things like that. And remember that the way each person presents is different, and that is modified by the amount of immunosuppression, either de novo like diabetes and things like that, or due to the immunosuppression which happens as a result of the organ transplantation. Yes, there is actually time frames where you see specific pathogens, and when you see unusual situations, always look for exposure as a result of which the issue is happening. And obviously there's a clear link between the amount of immunosuppression and the risk of certain infections. And once in a while, at least, you do get to see donor-derived infections, bacterial, viral, fungal, mycobacterial, and things like that. And so let's not forget that issue as well. And also remember that prophylaxis plays a major role in any infection. And in CMV, which we are going to talk about, the traditional recommendation is for 100 days or 3 months of an appropriate valganciclovir, especially in the high-risk situation where the donor is positive and the recipient is negative, but sometimes even for positive recipients, irrespective of the donor. And we'll talk about that in a little more detail as we go along. But there are other indications for which we do prophylaxis like pneumocystis and UTI and Candida. So to start with, you need to make sure that you get appropriate serologies. And in that list of serologies that you get, you can see that CMV is also clearly mentioned over there. And you need to have IgG documented for CMV before you start, because you want to know if the person is seronegative. The patients who are CMV seronegative obviously represent the highest risk group for developing CMV disease post-operatively or post-transplant, and therefore need a lot of additional observation. Also consider the underlying disease, time for post-transplant, the allograft function, use of prophylaxis, and rejection and its treatment for rejection. So obviously you need to do it aggressively when you see a sick patient. Make sure you have adequate tissue, routinely stage what the situation is, and also make sure that you interact with pathology and microbiology, because without synergistic activity, it is very difficult to handle a complicated patient as a transplant. And this will unnecessarily cause morbidity and mortality, and possibly even toxicity. Right. So when we talk about timetables of organ transplantation, remember that these are general guidelines. It is not absolute, because like I said, each patient is different. The epidemiology is altered by prophylaxis. So if a person is on specific prophylaxis, simplest example, CMV. If a person is on CMV prophylaxis, then we get to see more CMV as late CMV, meaning if they are on prophylaxis for the first 100 days, then some people may break through between day 100 and 150 with CMV when the prophylaxis has been withdrawn. So let's not forget about that. And also when we have unusual exposures, typically fungal infections, then you can have unusual timing of infection. So this is a simple chart that my colleague and I have made up about what you see when, and obviously there are things which modify it. Usually we divide into early, intermediate, and late in the first month, or for up to 6 months and beyond 6 months. And obviously modifiers include the skills and the, what you use in terms of serologies and level of immunosuppression, and also prophylaxis. And the usual infections in the intermediate stage is usually reactivation of latent infection and donor-derived infection. And viruses become very important in this group of infections in the intermediate group. And that's what we are going to primarily concern ourselves, because CMV has long-lasting and multiple implications with regards to prophylaxis and therapy. So generally, the early period, we know it's due to nosocomial or surgical infections. Typically, we see drug-resistant organisms like gram-negative rods, like carbapenem-resistant Acinetobacter and carbapenem-resistant Enterobacteriaceae and things like that. And we know that surgical skill and appropriate therapy and appropriate drainage and things like that plays a big difference. Traditional opportunistic infections are fairly uncommon, although you can have Candida and Aspergillus, especially in the 2nd and 3rd weeks. HSV can also happen in the absence of prophylaxis. You can have shingles, you can have herpes simplex coming out of the mouth and things like that. What we generally see, things like CMVs in the middle period, after about 2 weeks of transplant till about 3 months of transplant, even 6 months of transplant. And that's where we see the greatest risk of opportunistic infection. And here we call it immunomodulating, because CMV has long-lasting effects, because we know those who reactivate CMV also have a higher risk of having bad things happening due to, say, EBV, like post-transplant lymphoproliferative disorder. And they also have higher risk of other infections like fungal infections and gram-negative infections. We've even seen patients who develop CMV then go on to reactivate tuberculosis as well. Although I can't tell you the numbers are big enough for me to say that happens routinely, but to me it is a concern. The late period is typically 6 months after transplant, and usually it is the community-acquired infections which happen. But this is usually with good allograft function. So if somebody has had a liver transplant or a kidney transplant, and the amount of immunosuppression comes down to very little, then the risk of opportunistic infections comes down significantly. And it's usually things like pneumococcal pneumonia and stuff like that, which are the biggest concern. But again, it all depends. If a person's graft never works very well and they are permanently having a problem with their immunosuppression and they need higher doses than usual and they have chronic rejection, these are the kind of patients who never reach this late period, and many of them end up staying in the intermediate period for a very, very long time, if not forever. So let's start off with a case. This is a 42-year-old gentleman who underwent a cadaveric liver transplant for alcohol-related liver disease in March of 2019. This patient we were involved with. So his past history included being treated for tuberculosis in 2012. We could not get further details of that. He reported no other comorbidities. And March 2019, as you can see, he underwent a liver transplant. And he was on prophylaxis for CMV after that. He presented to the liver transplant center. This was done at another center with fever, body pain, and poor counts in late 2019. So what happened was that the whole transplant course itself was a little chaotic. Pre-op and post-op, they noticed that he always had low white cell counts, and the differentials are normal, usually about 1,000 to 1,500 white counts. Total white count itself was that much. So they did a bone marrow pre-transplant, they did bone marrow transplant. They all said really nothing much. So they went ahead and gave him tacrolimus, MMF, and steroids. And because the counts were so low, they thought it was unwise to give him any prophylaxis like cotrimoxazole or valganciclovir. And so now, as you can see, if I can go back to the previous slide, he now presents with fever, body pain, and poor counts. And this would be concerning for the possibility of CMV. And this is 6 months into transplant, and that's not good. So he was seropositive. He was CMV IgG positive pre-transplant. So he's not very high risk. Having said that, he's still in the risk group. So he had worsening pancytopenia in September 2019, requiring multiple transfusions. So about 4-5 months into transplant, all the cell counts were getting worse. And at that time, he also had worsening of renal function. His baseline was 1.3, and now his creatinine is 2.4. And so they worried about CMV, and they sent off a CMV PCR, and it was reported as in excess of 100,000 copies per ml. So I don't think it's a pretty no-brainer to figure out this person had pretty bad CMV disease. And he was started on ganciclovir IV, and this was adjusted to the renal function of 2.4. And he was completing 2 weeks of therapy. And in spite of it, the patient was quite miserable. He was still febrile. His counts were about less than 1,000 at all times. Hemoglobin was 4, platelets were 45,000. As you can see, pancytopenia. He still feels very tired and weak, and he just didn't look good. They were worried he was going to die. And at that point, he was referred to my team, and he was sent to my hospital for further evaluation. At this point, the question is, this guy has had the CMV treatment, and clearly he has CMV disease. He's been started on the appropriate therapy, which is ganciclovir, and in spite of it, the guy is not doing so well. So what should we do? Should we repeat the CMV PCR? Should we stop ganciclovir? Should we look for a new problem? Should we change to foscarnet? Or should we call infection disease? And for those of you who are not sure, the answer is always E, call infection disease. So the repeat CMV PCR was reported as in excess of 200,000 copies per ml. So obviously horrendous, no response at all. And the bone marrow examination, we just wanted to make sure there's no other infiltrative disorder. There was nothing. And there was no evidence of a new infection like TB or a fungal infection or any other problem ongoing. So obviously it was just CMV, CMV, and CMV. So the question is, should we go for resistance testing? Should we change to foscarnet? Should we just increase the dose of ganciclovir? Remember, he's on a lower dose of ganciclovir because of the renal dysfunction. Or should we call infection disease? And like always, we call infection diseases. So what did we do? We got the hepatologist to review that and try and see how we can reduce immunosuppression. So that was done. The ganciclovir dose was elevated. Now here, the cytopenias was not because of the ganciclovir. It was because of the uncontrolled CMV. And we decided, because of the acute renal dysfunction, we increased the ganciclovir dose to nearly what he would get if he had normal renal function. As soon as we did that, he started feeling better, meaning his count started improving to his normal numbers, about 1,000 to 1,500 white count from about 600, and he was doing very well in follow-up. And unfortunately, I wish I could say this was the end of it. So we told them to keep him on prophylaxis for at least 100 days. And on follow-up, again, once his counts started bouncing around, the primary team at the other hospital decided to stop valganciclovir, and we immediately relapsed back into CMV disease. And we had to rescue him again with ganciclovir, with a humble request not to stop the valganciclovir until we were very sure about what was going on. So to understand what CMV is, generally speaking, it is latent infection which gets reactivated post-transplant. Once in a while, it can be donor-derived infection. Very, very rarely, it can be a new infection after transplant. Obviously, there are recipient factors, there are transplant factors, and there are also post-transplant factors which can affect this. And in patients who are vulnerable to this, they can develop CMV disease, which can either be CMV syndrome, which is viremia with fever but no end organ damage, or tissue-specific CMV disease. So remember that CMV generally happens in the first 1 to 3 months post-transplant in the absence of prophylaxis. That is important. In the era of routine antiviral prophylaxis, the disease usually happens after the first 3 months up to about a year. But remember, anytime the immunosuppression is stepped up, you can relapse into CMV or you can develop CMV for the first time. So again, these timelines are in general, but you need to keep the patient's immunosuppressive regimen in mind to make pronouncements on the possibility of CMV. And of course, like I said, you have to be careful about CMV disease being CMV infection and compatible symptoms on histopathology. The only place where you don't need histopathology is CMV in the eye, where a good ophthalmological examination is considered adequate. But remember about CMV PCR. CMV PCR positive from non-sterile areas does not necessarily mean it's bad. So doing a stool PCR or a respiratory PCR does not necessarily mean it's CMV. Because even if you have, let's say, pneumocystis pneumonia, you can have CMV shedding in the bowel and stuff like that, which does not necessarily make it CMV disease. And the problem is you need to know that there are dynamics in this. If the CMV levels are very low, then you can be quite certain that it's not CMV disease. On the other hand, if it is very, very high, or if the person is significantly viremic, then yeah, CMV is not a passenger, it is a pathogen. And of course, manifestations wise, CMV syndrome forms the most common after organ transplant, and tissue invasive is the smaller part of it. And like I said, it can be a systemic syndrome or those associated with tissue invasion, and it can often be associated with other opportunistic infection. And it's very important to remember it's bidirectional. Just like allograft rejection and treatment for that can cause CMV triggering can also result in allograft rejection, which is horrendous. And of course, it's an independent risk factor for the risk of death mediated through the indirect effects. So not just that the CMV causes problems, it also has long-term implications in terms of poor outcomes. So generally speaking, when we talk about treatment of CMV post-transplant, the treatment is usually 3 to 4 weeks. Everybody thinks it's 2 weeks. That's not really correct. It's about 3 to 4 weeks depending on the CMV PCR titers. And of course, you look at the CMV PCR, you don't do it within the first 2 weeks because it doesn't make sense. The standard of care even today is IV ganciclovir. Oral valganciclovir may be used in extremely selected cases. Foscarnet is reserved for ganciclovir resistant CMV disease, but then again, you don't suspect ganciclovir resistance right off the bat unless you are in the high risk category. So generally speaking, if you're not responding to ganciclovir, maybe you're underdosing it or things like that. So please check for those things before you start looking for resistance. And you don't, at the end of 2 weeks, if the viral load is not budged, definitely you need to look at whether resistance is a possibility. The role of CMV IG is probably unclear. The one place where you could consider it is in CMV pneumonitis, and there is some anecdotal data to suggest that using CMV IG for pneumonia possibly may improve outcomes. So when you look at CMV disease or tissue CMV, if there is severe disease like pneumonia and things like that, you may think about giving immunoglobulins, and it can result in graft loss. Let's not forget that. So your therapy options are threefold: either reduce your immunosuppression, give antivirals, or in rare cases, think of immunoglobulins. And of course, you can either resolve or result in graft loss at that. And never forget the complications like rejection, invasive fungal infection, bacteremia, and of course, a late complication is post-transplant lymphoproliferative disorder. So again, how do you prevent this? The major strategies are prophylaxis or preemptive therapy. We have lots of options in terms of therapy today. And if you look at the current options that we have, valganciclovir and ganciclovir everybody is aware of. Valganciclovir is the workhorse for prophylaxis, 450 to 900 milligrams once daily. It's fairly easy to use, but it can cause cytopenia. Ganciclovir IV is preferred for therapy, and of course you have to watch out for cytopenias. Foscarnet is the alternative, but tremendously nephrotoxic. Cidofovir is once weekly. That's also an alternative, tremendously nephrotoxic. The two new kids on the block are maribavir and letermovir. Maribavir is appropriate for therapy, but it does cause a lot of dysgeusia and neutropenia. And currently, it has been appropriate for solid organ transplant. But if you fail maribavir, you can still go back to ganciclovir. Letermovir is now indicated for prophylaxis, and you need to know there are some specific side effects for that, and it is available both as an oral and IV. Brincidofovir has been given up because of the problems associated in the study. Leflunomide, again, can be used as a salvage option. Artesunate currently has been shown to be ineffective. Right now, there's not enough data with it. So what's new in CMV? We now know there is a lot of late CMV and disease, which is special in CMV. And we know that we are now seeing CMV later in the course of the disease as compared to earlier, possibly because we have more use of prophylaxis with valganciclovir on a regular basis. And here's the problem. It's usually after 3 months that the transplant team also take the foot off the gas in terms of the aggressiveness in which they monitor. And therefore, it's more likely to break through and cause problems. And therefore, you need to be even more vigilant about it. And what about ganciclovir resistance? It's more being seen today in India. Usually happens more in high-risk patients like lung transplant, especially when they're on long-term prophylaxis, and almost always in those who are CMV IG immunoglobulin antibody negative before transplant. And of course, the problem is doing sequencing for this to find out the mutations is still not very easy. Options would be combining foscarnet with ganciclovir, reducing immunosuppression, and maybe immunoglobulin. And of course, we don't know what else to do after that. And whether we can use valgancellullar prophylaxis is still a bit of a difficult problem. So obviously we need to know that you can't have a single option for everybody. Please understand that we know that some people have a higher risk of relapse and poorer response. Those who have very high viral load, those whose viral load doesn't come down very quickly, those who still have viral load which is persistent at the end of therapy tend to do very poorly, which is exactly what happened with our patient. And these are the patients who need more aggressive follow-up, and they need proper prophylaxis and probably reduction of immunosuppression to as little as possible. And so the current regimen is get a baseline pre-treatment viral load, monitor the viral load, and look at the viral load at the end of 2 weeks. And do not stop until the viral load, viremia is completely cleared. And remember that some patients may need treatment beyond 3 weeks as well. So to sum up, what will I say? Always start with making sure you know the serology of the patient pre-transplant, the CMV IgG status. Prophylaxis is what we prefer, simply because in our country doing preemptive therapy is very, very difficult, and our patients are not known to be very studious or religious in terms of making sure they follow instructions. It's far easier for them to just pop a pill on a daily basis rather than go get blood tests and things like that. So yeah, big problem. Suspect CMV breakthrough or late disease, especially in patients who've had prophylaxis early on, and after that they have problems like rejection and things like that. CMV PCR is now measured quantitatively in international units per ml because it's comparable across labs, and you need to know what the conversion to copies per ml is. So please check with the lab, whichever is doing it. Ideally, you should be doing CMV PCR in the same lab with the same kit, because otherwise comparability may be difficult. So even if a person breaks through on valgancellullar prophylaxis, the treatment of choice would still be ganciclovir, and you'd watch the patient very carefully. And if you repeat only after 2 weeks, if the PCR is positive after 2 weeks, then you need to ask if it is resistant and maybe think about adding phoscarnet. You can think about increasing the dose and then waiting while you're waiting for the workup to come back. And if the resistance testing is there, then you can think about adding phoscarnet or switching to phoscarnet, and always think about reducing immunosuppression. Also remember that you need to look for other problems associated with like invasive fungal infection and development of post-transplant lymphoproliferative disorder, secondary to EBV activation and things like that. And whenever you treat CMV breakthrough, always remember you will need to give secondary prophylaxis probably 100 days. And these are the kind of patients who can relapse later on as well. Anytime you increase immunosuppression, there is a chance that CMV can break through, and it needs to be watched very carefully. And like I said earlier, CMV disease and CMV infection is an independent risk factor for bad outcomes. And therefore, this needs to be handled very, very carefully. And these patients need excess attention, because you really don't want to lose them to a fungal infection. And with that, I will sum up and I will stop now. Obviously, we don't know everything there is to be said about this topic, and this is still a constantly evolving topic, and there's a lot of new information coming out. And I would advise all of you to keep watching the medical literature, because these are exciting times with regards to CMV in terms of the number of medical options that are coming through, and possibly, hopefully, these options will be available in India as well in the near future. Thank you, and I will take questions now.
Thank you, sir. Sir, since we're just on time, I'll go through a rapid fire of the questions which are in the chat box. So first question is by Dr. Bala, who asks about the new kid in the town, Letermovir, your experience with that, and is it available in India?
Actually, no, not yet. Letermovir is not yet available in India, but we are expecting it to be available hopefully next year. So it is going to be interesting. Let's see.
So another question by Dr. Bala again. What percentage of CMV and haploidentical stem cell transplant is documented in India?
I don't have the exact numbers. I can ask my colleague Priscilla, who handles a lot more stem cell.
I don't think we have numbers either. Yeah, we don't have the numbers either. I think we're just bringing it out. I should be able to tell you in a month. We're just analyzing the data.
It's interesting to wait for it. Next question is, do you use cidofovir in case of low counts?
Yeah, see, again, cidofovir is one of the options that you can use in resistant infections. And also remember, it's another drug which can be used in adenoviral infections. So yes, we have used cidofovir. And yes, toxicity is an issue, but it can be used. Remember, if the cytopenia is because of the CMV, then treating the CMV all out is the correct answer.
The next question is oral ganciclovir used for prophylaxis in your experience?
And liver transplant, it's not so clear, but for all the other transplants, oral valgal encephalopathy can be used in solid organ transplant. For stem cell transplant, again, if you look at the ESL guidelines, 2 years ago, letermovir was post-transplant prophylaxis in stem cell transplant for the first time. So I think obviously that may be a better option. But yes, valgal encephalopathy in solid organ transplant is a good idea.
This is Chandra here. Can I make a comment about letermovir? We've been using letermovir for the past few years. It's a wonderful drug in terms of efficacy. We have not seen CMV as much as we used to see. It's extraordinarily expensive in the United States. Each capsule is about $250 US. Each capsule is $250. And we give each patient from day plus 10 after transplant to day plus 100. So 90 days we have to give at a cost of almost $300 every day just to prevent CMV. I don't know what the price is going to be in India, so one has to use it cautiously. Have we run into problems with letermovir? Yes. There could be resistance developing to letermovir or CMV breakthroughs with letermovir. It is infrequent, but we are beginning to see, and if you look at the literature, there are lots of cases of breakthrough being reported with letermovir. That's the next thing I'm going to see in India, I'm sure. Right. As far as CMV and haploidentical in the United States, we about 60% of the people are CMV seropositive. So I would imagine it's very similar in the haploidentical population as well. Ganciclovir for prophy, Subra, ganciclovir is a toxic drug. In the stem cell patients, we do not use ganciclovir. That is why until letermovir came out, we couldn't use any prophy. In the solid organ, we use valganciclovir, which has much better bioavailability than simple ganciclovir. So in general, oral ganciclovir is discouraged for prophylaxis.
So a couple more points to that, Ramesh. One, in letermovir does not have activity against HSV or VZV, so we have to give additional HSV and VZV prophylaxis when you're giving letermovir prophylaxis. Second, letermovir is generally encouraged not to be a treatment drug because it's a low genetic barrier for resistance. So if the viremia is higher, you generally don't want letermovir in the mix at that point. Yes, salvage therapy has been done with letermovir, but generally it fails.
Excellent. Thank you.
Thank you, sir. So one case by Dr. Sujata, 6-month-old child waiting for liver transplant, primary CMV disease, suspicion of CMV hepatitis. When would you consider the liver transplant in this patient?
So you don't take in a patient with active disease into a transplant. It's just not considered a good idea. So primary CMV disease, actually the dynamics are very, very different. I assume this means this is vertical transmission of CMV from mother child. Obviously, that's a little more difficult to treat. It needs long-term follow-up. Again, it all depends on how quickly.
And just one last question is pending. So, at what CMV PCR cutoff copies per ml would you treat? Would you give preemptive therapy? So, would you like to give an answer for that?
Cytopenias additionally. So there is a drop in graft or drop in cytopenias, and as soon as you start seeing a CMV being positive, you start thinking about treatment as opposed to solid. You want to wait till a certain cutoff, for example. So it varies from transplant to transplant and their level of immune suppression and what do you anticipate. And we wait for a couple of CMVs 1 week apart before we decide in solids. It's a little bit more aggressive in the liquid side.
Thank you, sir.
May I make a comment about CMV PCR? One has to be very, very careful. I know solid organ transplants and stem cell transplants are being carried out in different institutions in India. And I am not so confident that all the labs have reliable CMV PCR data. I'm not sure how good each of those labs is in providing accurate CMV PCR. One has to be very, very careful. They should, it may be, I have my doubts that they have accurate PCR. So one to assume, so whoever the ID person working in any institution, please check with your virologist and microbiologist. Are they internationally acceptable? Are they compatible? Do they have validation before starting to do interpretation of CMV-PCR? It's tricky, and one has to be very careful because CMV-PCR is relatively new, only in the last 15 years. Before that, we used to use CMV antigen. So even in the United States, it's a relatively new tool. So I can imagine how much it could be misused or abused or unreliable data in many, many Indian hospitals. So one has to be super careful about CMV-PCR.
And plasma versus whole blood is completely different, as whole blood will pick up higher viral numbers. And when you use, despite using international units, you're better off correspondingly using the log values, because 500 to 800 is not the same as 5,000 to 8,000. So you have to look at log values and make a difference when you manage things. So at least 0.5 rise in log is the true rise generally. So not just copies.
Yeah, roughly speaking, 0.5 will correspond to 3 times the load.
Yeah. So hi Chandra sir. Vasant here, sir.
Hi, Vasant.
Hi, sir. So I wanted to ask a question. Even Ramesh, I think I had discussed with you this. We're having a lot of these post-COVID patients, and very worsening of the, some of them on ECMO and all that. And on ECMO, further worsening of the saturations occurring on these patients. And when we do the BAL CMV viral load, we get it sometimes in crores or even lakhs. But the serum, some of them have plasma CMV viral loads high, but sometimes there is a discrepancy. Like just now, I have a patient with more than 4 lakhs BAL CMV viral load who had worsening of the oxygenation. The X-ray had further worsened, but the plasma viral load is not very high. So how do we, is there just like a CMV colitis, we have a discrepancy? And especially there's a clinical worsening happening in these people. And in fact, in one of the samples, we cross-checked with Hinduja also. We had more than 33 lakhs of crores or something of that sort, the BAL CMV viral load, which was at Leelavati as well as at Hinduja. So we are seeing quite a few of them, and some of them have very, very high plasma viral loads also. So how do we go about this? Because there's a clinical worsening with very, very, very high BAL plasma.
Okay, so I think this is a fascinating issue. Let me make my comments and then others can jump in as well. I am not sure what to make of it. I don't know how to interpret presence of another virus in the presence of a viral infection. You know there are epiphenomena. Many of the viruses can be reactivated, and they could have viral presence without necessarily causing problems. And as you know, a BAL can contain CMV in perfectly normal setting. CMV is present in normal hosts in the oropharyngeal secretions. So presence of CMV, to equate that to disease or infection, I think it's a stretch. One needs to be very careful because the treatment is toxic. Ganciclovir, these patients are already highly lymphopenic based upon their SARS-CoV-2. You don't want to give them ganciclovir, which is severely myelotoxic. So based upon quantitation of CMV, and plus there is a great paucity of information in the literature about opportunistic infections in the setting of SARS-CoV, whether it is Aspergillus, whether it is Mucor, whether it is RSV, whether it is other opportunistic pathogens, there is not a whole lot of information. Even Aspergillus, we don't have absolute critical data that we can depend on. Many of the patients do not have galactomania. Just based upon the organism, we tend to give drugs. So you do not know what the role played by these organisms. So even if it is in crores at this point in time, because the treatment is toxic, I would be reluctant to embark on treatment based upon just the presence of the organism. However, if you showed in the bloodstream, it becomes a bigger concern, especially if you have a rising trend in the bloodstream, or if you have another target organ that you biopsied and demonstrated the organism in the parenchyma, then it becomes systemic disease. Outside of that setting, At this point, to my knowledge, literature doesn't talk about treating CMV PCR or CMV based upon CMV in the BAL fluid. I think I'll stop there.
Yeah, we strongly discourage quantification of CMV in the BAL. We just do it for identification purposes, but no, we do not do quantification in BL for the same reasons what Dr. Chandra explained. So because there is natural viral shedding. And so this confuses caregivers. And generally speaking, based on our other immunocompromised host experience, unlike GI disease, where you can have isolated GI disease, practically, when you have CMV pneumonitis, there is CMV viremia. That is practically, that seems to be the case. And stuff like so. In the absence of CMV viremia, if you have a lot of viral shedding on the BAL, we tend to ignore it at this point of time. So everything has to be taken a pinch of salt. What Dr. Chandra said is if you have a tissue biopsy, like a BAL tissue biopsy, that has inclusion bodies, that's a different story. Then you may want to consider management in that setting. But otherwise, this is a crapshoot.
Again, it also depends on the organ transplanted, isn't it? Because in the lung, at least there is some data about the severity of viremia in the bowel and the probability of it being infection. I think there was a publication in Transplantation Journal about 4 years ago looking at that particular issue. And they looked at CMV pneumonitis post-lung transplant and bowel shedding of CMV viremia, bowel shedding of CMV. Again, I agree with you that there is even if you look at it that way, there is no clear definitive cutoffs. And it must be said that these kind of numbers certainly do not exist for liver and kidney transplantation that I'm aware of.
Yeah, I think what Vasant is asking about is a COVID patient, not a transplant patient. So there are two different entities. Lung transplant with CMV is a story very different from a COVID patient with CMV. If you make a COVID patient analogous to an HIV patient, in the past, if you recall the pneumocystis times, there were a lot of patients with pneumocystis and CMV. We always ignored the CMV and treated only the pneumocystis. So, Vasant, please remember, presence of CMV does not mean you have to treat the CMV. We never treated the CMV in the HIV setting.
Right, sir.
Thank you, sir. In the interest of time, we move on to the next session. Thank you, sir, for a very comprehensive talk, and thank you to all the panelists for a very informative discussion. Fever, infection, signs of infections in immunosuppressant patients have always been challenging, giving a lot of dilemmas and an adrenaline rush when the eureka moment comes. And that is what our next session is about, challenging cases in solid organ transplant and on patients in immunosuppressants. For this, I hand over the mic to Dr. Vasant and Dr. Kirti to further moderate the session and introduce our esteemed panelists for the day.
Thanks, Parul. And I think today's session is going to be on interesting cases in transplant, solid organ transplant and patients on immunosuppressions. And for that, me and Dr. Kirti will be taking the role. And we have Dr. Vidya, Dr. Prasila, Dr. Nitin Bansal, and we have Dr. Vikas Deswal and Dr. Kanish. So welcome, and we'll have a interactive section for this. I think I'll start off with the first case.
And Dr. Mayur as an expert. Okay.
Dr. Mayur, yes. So this is the first case. A 63 years male was a resident of Mumbai, businessman, hypertension diagnosed in 1999, CKD diagnosed 2006. Non-diabetic, he had a collagen workup for the cause of the CKD, which was completely, they couldn't find out. Finally, he underwent a renal kidney transplant in November 2008. He was initially on steroids, MMF, tacrolimus as immunosuppressant. Actually, it's a long story and he has gone through all possible infections which are there. Tacrolimus was withdrawn as patient developed severe hyperkalemia and creatinine. Tacrolimus was replaced by everolimus. He received empirically AKT for right pleural effusion, and unfortunately, after the tacrolimus, he had an everolimus induced acute lung injury where he was admitted at Lilavati in July 2015. He was on ventilator, tracheostomy, and completely recovered with methylprednisolone. The differential there, it was PCP was thought of, but that was completely negative. He was finally on MMF steroids. Over a period of time, he had recurrent UTIs. He underwent a cholecystectomy for calculus cholecystitis. He had blood culture, salmonella typhi. And then after all this storm, he was all right for a year's time. And this is the case we have to discuss now from here onwards. In June 2017, this patient developed mild cellulitis of the right dorsum of the hand, left arm, which was treated with amoxicillin followed by teicoplanin. The cultures were negative. Skin biopsy showed, because the number of lesions went on increasing without any clinical improvement in this patient, and finally thought of doing a skin biopsy, which showed bacterial, fungal, and AAP cultures and gene expert. Everything was negative, and the histopathology just showed non-specific inflammation. Partly patient recovered and he went to a holiday to Greece for 7 days. And after coming back from Greece, patient developed severe pain, swelling, and erythema of both the lower limbs. He started developing ulcers with serous discharge from the lower limbs and also from the upper limbs. It was diagnosed as acute panniculitis and enthesiastis. He was readmitted at a peripheral nursing home, his brother's nursing home, and these are the photographs where he had this multiple lesions all over. That is both the lower limbs and this is the dorsum of the hand, and they kept on coming at different places, and these are all the lesions which he developed over a period of 2-3 months. Painful, severely morbid, and he was just not able to move from it. So at this juncture, he is a patient with kidney transplant over a period of time. There had developed tacrolimus adverse reaction, then everolimus induced acute lung injury, and then he has been having this over a period of time on MMF and steroids, multiple disseminated skin lesions occurring, and which were not, even the histopathological and the cultures were non-conclusive at this juncture. So I would ask the panelist, what would you think of this juncture when your micro and histopath is not supporting your diagnosis? How would you go about it? And what would be your differentials?
Can I start?
Yeah.
So this is basically a host who has been exposed to a lot of immunosuppressive medicines and after transplant. So he has got skin, soft tissue, inflammatory lesions, and underlying T-cell immunosuppression, for which the basic workup for the bacterial and TB or mycobacterial cultures is negative, and is not responding to antibiotics. And these are this has progressed to all over the body. I think what I can see from the images. So definitely it's a disseminated process. So what I would like to keep as my differential diagnosis would be a fungi. Particularly what comes to the mind is Streptococcus, first of all. And secondly, since he went to Greece after all these things happened, so that travel history may not be significant as of now. I would like to definitely know whether he was exposed to some other bugs which are found in the water, mycobacterium, NTMs, or other pathogens which are found in the water. That's what I would start with.
So he was not exposed to, he did not venture into the swimming pool or anything, knowing that he's a transplant patient and he had already had a long, if you see multiple, so he did not have any of these exposures, or he did not venture into any of these.
The differentials will be nocardia and nocardia also. That's what I.
Yeah. I mean, basically, I think we would go by it by see what are the bacteria if we look at nocardia and I think you have it all on your slide. Okay, nocardia or probably meloid. These are the things that we would look at in Indian setting, but the appearance of these lesions don't seem to be that way. So the other infections probably I would really think of could be NTMs. Yes, particularly involving the skin soft tissue. If you look at it is Chelonae, fortutum, and hemophilum also, but we do not have exposure to water, but still I will still keep NTM on thing. And if you look at infections due to fungi, Fusarium, Pseudosporium, Lumentophora, all these also can cause skin soft tissue infections. One thing we also have to keep in mind probably would be certain other dermatophytic infections like say Malassezia, or all these also can actually cause quite severe infections in immunocompromised. Yes, we do see rarely, not rarely, we do see these immunosuppressants per se causing infection, causing, say, sebaceous hyperplasia, or when it comes to everolimus, oral ulcers, etc. So these are some of the possibilities. Like Dr. Nitin discussed, when we look at a disseminated infection, I probably would like to see if he has any other site involvement, say the lung or spleen, etc. So I think if the biopsies have been inconclusive, we would want to look at his basic labs and images.
So Vidya and Nathan, thanks for that differential. And I think if you see this slide, he had counts were borderline high. His creatinine was also on the higher side. His creatinine clearance would have been less than 20 because hardly weighing 40 kgs. His further investigations, the CT scan chest, abdo, pelvis did not really be contributory to the disseminated skin lesions what he had. And his TB cultures on the left arm nodule biopsy. In fact, we not only the punch biopsy, but a complete excision surgical biopsy was done for this patient. And the gene expert and the left nodule biopsy, it showed all the majority of the investigations, and even the vasculitic parameters, everything was non-conclusive at this juncture. And so the patient was thoroughly investigated, and the only thing is that he had lymphopenia, creatinine raised, CT chest showed 3 nodular opacity in lung, left lung, another tiny nodule in the left. I don't have the CT scan of this. His CNV PCR was 12,000 copies, and his galactomannan was 4.5 at this juncture. So anything further? I mean, how do you go about this? And so none of whatever investigations with their scanning, imaging, what was done. So he did not have any other specific organ involvement except for some doubtful, the CT scan showing small nodular opacities, which were of doubtful significance.
So, just summarizing the case again for everyone. So this is a kidney transplant patient who is presenting in the late post-transplant period, exposed to multiple immunosuppressive regime and severely T-cell suppressed. Now is presented with disseminated cutaneous lesions, and has got nodular opacities in the lung and with a raised galactomannan. So skin and lung involvement and initial improvement with the moxiclav, I would think on the lines of nocardia to be very high on the card, because initially, as Dr. Nagavekar has described to us earlier, that he had initially improved with amoxicillin clavulanate. So could be nocardia still hanging around there as a differential. We may not have been able to pick it up. Other thing which I would still consider as one of my differential, and we don't know the serum cryptococcal antigen levels, is the disseminated cryptococcus involving the skin and the lungs, because nodular lesions are fairly common with cryptococcus. So that would be another differential. Although all the possible differentials have been discussed by my co-panelists, one thing which I would like to add, which is little off the mark considering the travel to Mediterranean and Greece, is the leishmaniasis, cutaneous leishmaniasis, which I would like to add in the differential. The next step I would do is do a bronchoalveolar lavage and try and get a biopsy from the nodular lesions, and do a serum cryptococcal antigen. Those would be my next step.
Right. I think that leishmaniasis was a good differential for this patient, and I think cryptococcal antigen was possibly not done in this patient, but nocardia was another very good thought. But he had large, painful erythematous ulcers and almost abscesses, which used to so at multiple, almost at, extensively all over. So that was, and I think twice a skin biopsy was done, and finally the third time also a repeat skin biopsy was done. All his sputum cultures for bacterial A, B, gene export, everything was done, and the skin biopsy which was done and it was sent for a second opinion also did not give us any clue. And finally, this was from the histopathologist, from a dermatologist who deals only with histopathology, and finally gave this impression as linear IgA dermatosis. Any further differentials? I mean,
So Vasant, just a question that I wanted to ask was it painful nodules which ulcerated, and at what period of time? Because I think that's a key actually. So I mean, I like the way all the panelists have approached it, and this is what an ideal physician would definitely think of. But I think the key here was the fact that the painful nodules ulcerated, they had a panniculitis-like syndrome, and that was the important thing here. And I think that should actually definitely be considered. The one thing that to consider as a panniculitis-like phenomenon is two things. One is also tuberculosis, which can present with an erythema induratum kind of thing, and it looks exactly like this. But these are multiple, so that would totally go against the diagnosis. And with regard to leishmania, the multiple lesions that he had, were they only in the lower limbs and the exposed areas, or did it involve non-exposed areas as well? Because if it is exposed areas, then yes, I would agree with Vikas that Mediterranean region, you would think in terms of cutaneous leishmaniasis, maybe major. Leishmania major.
Priscilla, the duration of the illness was almost 6 to 8 weeks. So it was almost a chronic illness. It was started with acute small, and it gradually over, and all this workup, it took almost, so I think it was almost 8 to 12 weeks. By then, still there was no diagnosis of this patient.
So how did the patient do? Did you give him any specific treatment? Oh, sorry. Go ahead.
He was put on IV, liposomal amphotericin B, Valgan. Apart from antibiotics, the dermatologist, histopathologist said this is IgA dermatosis, and he was put on dapsone. And I know that I've been called to this physician. Actually, he only has given me all these details, and I've been involved in this patient for a long, long time. And then he was put on the ventilator because he became severely hypoxic. And when I went to see him, I thought he looks like a possibly some opportunistic infection. But when I went and saw that his ABG was, the PO2 was okay, I just put the blood on the floor, and it was, it had turned bluish. And finally, it was, I came to know he was on dapsone, and that it was actually methemoglobinemia. But that had nothing to do with the ulcerations what the patient has. And he reverted back, and he was extubated the next day morning after the reversal of methemoglobinemia. There was no improvement in whatever medications were given. So what next? So histopathology 3 times done, a full-length skin biopsy was done, which also did not show any improvement. All the respiratory workup as well as the imaging workup of course, was done, which did not pick up anything. Of course, the PET scan was not done at that time, during that time, 2017. That's the only thing. So finally, any other differentials? I think we have discussed almost quite a few of differentials, and I think we would fit somewhere into whatever has been discussed.
I have one thought. We can see a lot of cutaneous T-cell lymphomas, which can also look like this. And though I must say, I have not seen a PTLD presenting as a cutaneous T-cell lymphoma, but a lot of these weird skin lesions with a panniculitis-like syndrome, cutaneous T-cell lymphoma is a differential to consider here.
Can you have a delayed or a chronic GVHD-like skin differential here? I mean, is that a possibility?
Only thing in solid organ transplants, we don't see as much as the GVHD that we see as in hematopoietic. So I'm really not sure. The second thing I wanted to just find out was, what about what was his actual basic disease for kidney transplant? Was it?
So that,
I mean, because we said we don't,
so
we didn't have an autoimmune workup and all that. Because again, these lesions which present as panniculitis can also be associated with autoimmune conditions. So
yeah, so his autoimmune workup was done, but meaning they couldn't come to a reason why he has this chronic kidney disease, and that exactly the reason why this patient we worked up for PNK, CNK, and all the vasculitic markers again, in spite of after prolonged transplant time. So all that was negative with there. T-cell cutaneous lymphomas do present with nodular lesions, but I'm not sure whether they will have ulcerations. I've seen a T-cell lymphoma presentation, patient presenting with multiple nodules all over, and yeah, that was a very good thought again, Priscilla, about one of the differentials, which can be possible because some of the dermatological conditions which happen in solid organ transplant patients present could be, as a presenting as malignancy as well.
Sorry, sir. Can I ask something, sir?
Yeah, because yes.
Sir, where is he from, sir? Sorry, is he
Mumbai.
Northeast or something like that, sir?
Mumbai.
Mumbai.
Yeah, anything differential from Northeast? I mean,
I was thinking of looking at the cutaneous lesion. Could it be penicilliosis if he's from the Northeast in Assam or Manipur, or from even from Thailand if he has traveled to Thailand? So that was my thought behind that.
Priscilla, I think,
so Vasant, was the lung lesion related to the skin, or do you think the lung lesions were purely related to the methemoglobinemia? So if we thought of penicilliosis and histoplasm, those are systemic diseases, so they won't be limited, skin limited. So since here the description seems to be a skin limited problem with painful nodules under the skin, which later on went on to ulcerate, right? In the setting of a prolonged immunosuppression, patient is, I think, almost 5 years since the primary diagnosis. So yeah, sorry. So anything about pets, or do we have any pets, or any other thing that we should be thinking about?
Bartonellosis is one differential, but they did not have any pets. But of course, you don't require to have, that was another differential which can present with, but there was no hepatic involvement as such in this patient. Like they will develop hepatitis and all that for disseminated Bartonellosis, which can present with such. So finally, his blood cultures gave us a diagnosis. Any guesses?
Was it Fusarium or
Burkholderia pseudomallus?
Yeah, that's another thing. Yeah, because he improved on Amok's cleft, right?
Yeah. So this was a diagnosis. The blood cultures grew and mycobacteria. It was NTM. I think all of you did mention about non-tuberculous mycobacteria. It was a very, very rare mycobacteria, Mycobacterium malmolse. And finally, even the ID, this was at Hinduja. Dr. Camilla ma'am had diagnosis. And I think this is something which I just thought I'll discuss, that sometimes this mycolytic bottles can have a better...
So, Vasant, can I ask a quick question? Yes. So this patient did not have a systemic syndrome at all, right? So the blood culture being sent for atypical?
It was just sent, it was not sent for atypical, Priscilla. It was just sent as we did not send in mycophenolate at all. I'm just adding the slides to that. It was just sent in a normal, Bacton resin bottles, that is extent. It was not suspected at all. It was just sent, and those blood cultures showed AFB, the cultures.
Sir, why was the galactomannan positive plus 4.5?
So that could have been a false positive. That was just that was the report which was there, and I just put it up. But it was a false positive galactomannan positive. I do not know. The piperacillin tazobactam, what was used that time, I don't remember that. Whether that was from a generic brand or something, and that could have given a false positive galactomannan.
So just multiple blood cultures, Vasant, or just the one?
Multiple blood cultures were sent over a period of 3-4 months, but none of them had picked up. But finally, this blood culture, the last one which was sent.
So it was just one out of how many blood cultures that picked it up?
No, I don't remember now how many blood cultures that Mycobacterium malmolse was picked up. Because this patient during that time was admitted in this physician's peripheral nursing home. So just to show you,
do you think it really? Did he set?
Sorry, Priscilla. Sure. Yeah, because we did not.
No. I was just wondering. It's unusual, this whole presentation. Yes, atypical mycobacteria is a diagnosis for somebody with just skin lesions. But I would have expected the diagnosis of atypical to come from the skin biopsy rather than from, or a skin biopsy or a deeper biopsy culture growing that, rather than a blood, when he did not have a systemic syndrome. So I'm just wondering how we're going to tie all this together because it doesn't kind to sit in, so I was just go ahead.
Yeah, I agree with you, Priscilla, because the histopathology would have straight away given the diagnosis either, it's a granulomatous disease or the cultures, but none of them picked up for, I do not know the reasons for why it did not pick up. And so finally, I'll not go into detail about this. I'll just show you the, this is another case where Mycobacterium malmoense, a rare cause of disseminated cutaneous infection, which has been hardly reported. I just tried to look for the literature. There was hardly hardly cases of skin and soft tissue purely for malmoense. This is the only which one I found. This is about various skin and soft tissue infection caused by non-tuberculous mycobacteria. So considering this NTM, because we did not have any answer, this patient was put on rifabutin, clarithromycin and ethambutol, and these were the skin lesions at 4 weeks time, which showed completely healed and all the lesions. So it was a therapeutic challenge also, which definitely showed a dramatic clinical improvement. Patient, all the lesions disappeared, and he received 1 year of treatment. So this was another article, NTM in solid organ transplant, but majority of them will have, in this article will have skin and soft tissue, mycobacterium, abscesses, chelonia and all that. But finally, to end this story, he went to USA, I just complete, and he came back from US and he was doing well. And then he again started with, after 2-3 years, again, he rheumatic skin lesions, all his workup was negative. And he again got admitted for all these skin lesions at Global. And this time he had an abscess on the thumb. The surgeon said, I put him on, for some reason, liver node or floxacin. I thought he's all staphylococcal, all the blood cultures were negative. And that abscess, I sent it again to Hinduja, and it showed 3+ AMB+, and the gene expert was negative. Again, I put him on the NTM line of treatment. His CD4 was only 14. And this is after the, NTM line of treatment, all these lesions completely healed. So I believe that earlier also therapeutically, he completely improved, and this is also showing a complete improvement. So I think I'll stop this. Finally, developed H1N1, then complications, and finally succumbed on 17 June 2021, but not because of NTM. I think I'll stop share my screen here, and we can have.
If we would have not succumbed to the illness, we would have kept him on some like a lifelong prophylaxis. If so, then which
he was already on treatment. This was in March. He came to Global in March.
So in between the 18 to 21 or after 21, because you have 2 episodes, whether we will keep him on like a cryptococcus.
So one was in 2017, and this time it was 2021. So there was a 4 years gap in.
If we have not died, we would have kept him on some prophylaxis.
Maybe, possibly.
But what was the CD4 that you mentioned, Masud? What was the CD4 that you mentioned?
14.
Sorry, say that again.
14, because 14. So this time when he got admitted at Global, so he was put on anyway on the NTM line of treatment. We did put him on fluconazole, all those prophylaxis, whatever is there, because he was quite morbid. So I think 2 therapeutic and both the skin lesions presenting, and I think second time we had 3 AFBs from the local site, which again, and earlier also he responded completely to the NTM line of treatment with those pictures which showed complete healing.
Just wanted to add one thing. So this was a post-transplant person. In such a situation, we always have to keep in mind that there can be multiple pathogens causing multiple manifestations. So the traditional thing we always do in the immunocompetent patient, that you try to explain all the features with one syndrome. We should not always try to do that in this type of patient. So this patient had disseminated ulcerative skin lesions initially, also lung nodules and positive CMV, positive galactomannan, and also a methemoglobinemia due to the treatment. So just something to be kept in mind for this type of patient where, different things were probably due to different etiologies rather than the same thing.
Right, Ganesh. So it was nothing. These were all those. He has gone through a tough journey. I mean, just wanted to show the biography of this patient, what he went through from beginning till end. In fact, there were some things which I missed. He had a diverticular perforation, and that was treated conservatively, and he got better with that also. And then he had this H1N1 after being on NTM line of treatment. That also he got better. And I think that finally he got secondarily infected with the CD4 of 14. I think then it didn't make. And he was admitted not with me during this time. He was in a peripheral nursing home. So this was the journey of this patient. But twice he had an NTM infection. So we don't know whether they should be, if the CD4 is very, very low, whether they should be put on lifelong prophylaxis, just like we put Bactrim. He was put on Bactrim Flucon, but this NTM he completely recovered. Both the times he recovered completely. So this time he did not succumb anything because of that was not the reason. It was an opportunistic bacterial sepsis which killed him.
Question in the chat box. One asked, how many days did it take for the mycobacterium to grow in the blood culture? And the other is regarding whether the BAL was done in a patient with lung nodule post-transplant.
I think it was, I think it was around, the blood culture bottles were kept for a longer time. This time, I think the physician, who is a brother himself, had spoken to Camilla ma'am, and the blood cultures were kept for a longer time. And I think it was around 10 to 12 days where the blood cultures flagged. But normally this would happen with the rapid growers, but this was not. So I think we can, yeah.
And just a small mention of an interesting comment by Soman says, sirolimus can also produce similar skin lesions. So that was one of the differential we can consider in the initial.
So can everolimus actually.
Yes, ma'am.
So I thanks organizers, Neha, and it's like having a post test because already we have such a wonderful sessions with Dr. Chandra and Dr. Mayur. So this is like a post test exam when the cases are being presented. So actually the patients with solid organ, they stay with us almost for a lifetime because bone marrow patients tend to recover. As Dr. Vasant's patient was also kept on having multiple infections. I'm also going to present this kind of a different spectrum of infections which my patient had. This is Mr. S, a 57-year-old man who had underwent a liver transplant 10 years back. He was in an immunosuppression with tacrolimus 2 mg and prednisolone because normally the immunosuppression is generally less, but he was on a more immunosuppression because he had multiple rejections in the first 2 years, and also recently he required a plasmapheresis. Baseline creat was 1.5 and it has been like that for last 8 years. Presented with early satiety, occasional abdominal pain, weight loss of 10 years in last 2 months. He was feeling feverish on and off for maximum temperature recorded around 100. Examination was completely normal, except he had a mild tip of the spleen which was private. There was no clinical symptomatic impairment. His investigation, his hemoglobin was 8.5, his total count was 4,500, differential was normal, platelets were 129, creat was 1.9. Other investigations were unremarkable, alkaline phosphatase. Anemia was evaluated, serum antifungal have iron deficiency, blood also was positive, B12 and folic acid were not. So at this point, can I ask the panelists what differential diagnosis they think of if they want to put it in a syndrome?
Kitty, could you summarize the case, please?
So this is a post-renal transplant, quite a normal course, 10 years down the line, has low-grade fever, with, for almost 1.5 to 2 months with a weight loss and iron deficiency anemia, which to locate blood positive. The spleen.
So also had cytopenias and weight loss 10 kgs, correct? Yes. Since Kirti mentioned Chandra sir before the case, I think
that was not a clue.
So is that the cheat code answer is CMV, but also obviously histoplasma, many other viral illnesses, others are all possible.
Any other information you want?
Looking at the time frame, you said it was all 10 years ago, right? And multiple rejection therapies. So he has presented with the pancytopenia with splenomegaly and plus or minus GI involvement because there's some occult blood positive in stools. So I would look at diseases like involving all this, which is disseminated disease, tuberculosis, histoplasmosis, crypto, and I think PTLD is another possibility because he's because of the presence of cytopenias and so profound constitutional symptoms. I think you mentioned about lymphadenopathy being absent.
So these are the differentials were considered. As correctly said by Vidya and Kanish. So any other information panelists want? So this is what we evaluate a post-transplant host, depending upon a type of a transplant. This has been already put by Dr. Subra in his talk, so I'll go quickly through this. So if we want to complete a syndrome, then post-transplant with intensification of immunosuppression, with a lymphoreticular, there is no lymphoreticular involvement, with baseline EBV status being negative and IgG was positive. He received a primary prophylaxis in initial 1 year with valfenazine. So do we need to reorder the differential, Vidya?
I'd still keep tuberculosis, histoplasmosis, on the top.
Yeah, so we consider tuberculosis, post-transplant lymphoproliferative disorder, cytomegalovirus because of the recurrent immunosuppression, and he's been off prophylaxis. So late CMV as mentioned by Dr. Supra, cryptococcosis, although he didn't have any skin lesions or CNS or lung involvement, Aspergillus and histoplasma. So a diagnostic procedure was done. So which one of this will be a diagnostic procedure, or multiple procedures will be required as we expect multiple pathogens in this patient? So bone marrow, upper GI scopy, PET scan, all of the above. Any of the panelists, which one or multiple diagnostic procedures were done?
I think all of the above.
It was one.
See, because he has some GI, I know he has positive blood, occult blood positive in stools. I think it's important to do a scopy as well. In the presence of fever and cytopenias, I'm sure bone marrow is going to yield something for sure in this patient. And to prognosticate the disease, to know the extent of the disease, I think I would require an imaging. So.
Yeah, but the diagnostic procedure was a gastroscopy, which revealed a non-Hodgkin's, high-grade lymphoma. So, because of the EPV negative, he turned out some exposure in the last 10 years. He turned out to be seropositive and turned into having a PTLD because of the intense immunosuppression which he required. So, this was, everybody will feel this is the end of the story, but there are multiple twists. Hold on your seats. So, this is PTLD. It's reactivation because the EPV. Highest incidence is seen mainly in the pediatric population at the kidney. Kidney being the first, liver, heart being the second, and heart lung after that. And as we see what are the risk factors we should look for, again, childhood, deceased donor, negative EBV serology. So our patient had negative EBV serology, and if there is induction agent with monoclonal T cell. These are the risk factors for reactivation of EBV. And generally, it is treated, main treatment is reduction of immunosuppression and rituximab-based therapy. So yes, our patient was started on rituximab and his immunosuppression was reduced. So whether it can be, this is a question again to the panelists, whether it can be prevented or whether it can be preemptively monitored. As we know that our patient is EBV negative, anything could have been done to prevent it. Anyone of the panelists or Dr. Chandra and Dr. Sudha?
We could have done the serial EBV PCR monitoring, and based on the institute, I think the cutoff is, I think, 10,000 copies per ml. That is high, we can go for preemptive rituximab infusions also. That is also a protocol.
Yeah, that's protocolized based, mainly it is defined for the pediatric age population. But for the adults, we don't have protocols very well established. There is no Indian data available for that. So because of the cost constraints, many other things needs to be modified with us. So what normally we are doing with the heart transplant, mainly the pediatric population, which are at a high risk, we monitor EBV negative patients, IgG negative patients at initially for at least 2 months at 6 months if they don't have any syndromic involvement. So this was the same study which was preemptive monitoring with EBV quantitative PCR has been shown benefit. There is also few data suggestive of giving preemptive rituximab like once in a month or once in 6 weeks if there is a rising EBV titers. The data is small, but yes, there is. So he also, from the same biopsy, when we had a discussion with the histopathologist, they also mentioned positive IHC for CMV. So do we consider it to be significant? His CMV quantitative PCR from the blood was negative, and syndromically he didn't have any diarrhea or any lung involvement. So should we consider this as a significant CMV reactivation? The panelists, thank you.
Were there intracytoplasmic inclusion bodies?
Yes. There were intracytoplasmic inclusion bodies that were positive on an IHC.
So considering he's going to go for rituximab therapy, we will have to take it seriously.
Yeah.
So there is a data regarding what we will start with. He was started on RCHOP, and he was also given ganciclovir followed by oral valganciclovir, and he received 2 cycles of chemo, and he had a prolonged and profound neutropenia after second cycle of his chemo. So this was the data which was published in 2016 Gastroenterology, which suggested with being a CMV quantitative PCR from the blood being negative, still can be considered for the treatment. But this data included non-malignancy based GI biopsies. Our patient had a documented GI biopsy, so that was the twist whether it should be really considered to be significant. Because of the rituximab therapy, we have to take it as significant as a also with the PTLD, which is itself a reactivation and active CMV disease. So as I mentioned, for the second cycle of the chemo, he continued to have neutropenia, which was little prolonged, continued to have fever, and even he came for the next chemo cycle. We did his routine blood cultures, paired ones. He didn't have any center line, he didn't have any chemo port, and his blood culture came to be reported as yeast.
Cryptococcus, isn't it? Was it?
Differentials, what we will consider?
I would think of Candida, Cryptococcus. Those are the 2 main things I would think of.
No skin lesions. Still you want to go ahead with Cryptococcus?
Yeah.
Any other differential? So what we considered was, correct me if I'm wrong, Dr. Priscilla, normally when the blood culture comes as yeast, not a tissue sample comes as yeast, these are the only 3 pathogens which we consider. It's Candida, Fusarium, and Cryptococcus. All others can be positive from the tissue, but not from the blood. So yes, this was the 3 differentials which we considered. Out of these 3, which is the first order of preference, Cryptococcus we will consider first, or Fusarium we will consider first. It didn't have skin lesions.
So Katie, actually looking at the patient, what were his Candida risk factors? And I think you mentioned quite a few things which didn't suggest that it could be Candida. For one, he didn't seem to be hospitalized at that time. He was neutropenic. He did not have any long lines, no ports, no antibiotic therapy, nothing else that was going on. So, and the fact that he's like so far off from transplant, and this is kind of something that you see in kidney transplant patients very often. They have a fever which doesn't settle, and invariably you end up with Cryptococcus as a differential. So that's the only reason I was thinking of Cryptococcus, because of the way you beautifully mentioned it in the history, ruling out the Candida. So that's what I was thinking. But yeah, you're right. In the blood cultures, these are the things that can be positive. He's not a stem cell transplant patient, so I would put Fusarium lower down the list as compared to the others.
Yeah, so it was Cryptococcus in the blood. So he had a cryptococcemia. So what are the next things which we will decide our therapy for Cryptococcus? So overall clinical issues is post-transplant attachment prednisolone with B-cell lymphoma with CMV reactivation, on chemo with rituximab, now has Cryptococcosis.
CSF, oh, you mentioned that CSF is negative for cryptococcal antibody.
Yes, CSF was negative, CT brain was normal. So we got a CSF involvement to rule out if it has any meningitis. There was no meningeal signs. So,
did we do a PET to start with?
I didn't get you.
Did we do a PET scan to start with?
We did a PET scan to start, which was having involvement of mainly the GI mass. There was no major. I forgot to mention that there was no major lymph node involvement.
Anything in the prostate?
No, he didn't. So, what treatment regimen we will choose him on, and what interactions further we will consider.
So I think the most obvious one is fluconazole and tacrolimus, isn't it? So that is going to be a huge problem. Even if we can monitor TAC very closely, it still is a bit risky. So I guess if your kidney transplant physician doesn't kill you if you ask them to switch to something else. I mean, in some cases we've tried sirolimus and prednisolone because only TAC kind of interacts quite a bit with fluconazole. But yes, this is a tricky situation and there's no right answer. You could go with liposomal amphotericin B, but I think it's easier to kind of change the TAC in most of these cases.
Yeah, that's what we did. We changed the TAC to azathioprine. Finally, the renal guys agreed. So he continued to go with fluconazole and amphotericin B. We decided to undergo the chemotherapy after 15 days of therapy with ampho. That was the plan made, but it didn't go that well. These are the interactions I just put for the reference. So why did we change? Because the fluconazole has interactions with tacrolimus. It will increase the TAC level and toxicity and ultimately renal failure. So we changed the TAC to azathioprine. Patient was started on amphotericin B. He had a severe ventricular tachycardia after 5 days of of amphotericin B. So we could not give the further amphotericin B to the patient. Patient refused to go with that feeling. Patient refused to take further medicines with amphotericin B. We changed him to the fluconazole, and which was given 800, and then 400 was continued. So according to the guidelines, expert panel can comment whether we should have challenged him with liposomal amphotericin or deoxycholate in view of severe disease. Our patient had all risk factors.
Why did we give such a high dose of liposomal amphotericin? 5 mg per kg?
5 milligram per kg, liposomal, 3 to 5 milligram. We chose to give him, he was 50 kg.
Cryptofocus can choose a little lower dose also. That's what I was saying.
We chose the 5 because of the 3 to 5. So initially the creat also was 1.5, so we chose. So this is 2010 guidelines which mention actually a use of liposomal amphotericin B to treat it as a CNS disease, and only as a B2 recommendation they recommend what we have done as continuous fluconazole. So we might need to take the fluconazole lifelong with monitoring of his drug interactions. Eventually, he recovered from the PTLD and cryptococcemia, managed on azathioprine and steroids. Did not follow up for almost 1 year. So it is very important to us as the host. There can be multiple syndromes, and we have to look out for the drug interactions and predict, like as we discussed, like EBV, PCR to be managed. This is not the end of the story. He was in July. He presented. I don't know how much clear it is. He presented with these skin lesions. And he had been there for last almost 2 months, but there were no other systemic symptoms. There was no fever, no weight loss, no cough, nothing. Mentions for this, he is a guy who is on immunosuppression. Now the immunosuppression is much less because it's down almost 12 years down the transplant. Azathioprine and steroid, that's all he's on. He also is on fluconazole. The nephro guys were adamant to keep it for beyond at least 2 years. That's what they wanted.
Were these lesions in a single dermatome?
No, they were in multiple dermatomes. One was mainly on the back. This was on the sacrum area, the first one, and the second one was on the lateral side of the right, lateral lumbar region. They were itchy. They were having thickness can't be judged in this picture, but they were thick lesions, no developments. But there was no, there were no reds, there were no lung, there was no cough, the imaging of the lung was normal.
Was it just papules kidney or was it nodules?
It was nodular region. It was thick. They were non-painful with little bit pustular, I think. That can't be appreciated, but erythematous lesions, non-painful.
No other systemic involvement at all. That's what you had said.
No systemic. They have been there for last 2 months. Actually, came just in.
So was he adherent to his fluconazole?
Yes, he's taking to lesions.
What was the distribution of the lesions? How widespread? Where was it?
They were on full his like his sacrum area. They were full lumbar and sacral area.
Lumbar and sacral area only.
So again, we'll have to approach in the same way as we had approached the previous case. He is a post-transplant host who is presenting in a late post-transplant period, recently had a cryptococcemia and PTLD, received R-CHOP for that. now has these nodular kind of lesions on the lower back, as you described, and they are not limited to one dermatome. So the differentials would be pretty much the same as we had discussed earlier. Cutaneous localized nocardia, non-tuberculous mycobacteria, even staph folliculitis, TB, those would be my differentials. If he was not adherent on therapy, maybe cryptococcal skin lesions. So those were my thoughts. Those are my thoughts for this case.
But nocardia has to be bypassed. There is no history of any puncture or anything. Generally, localized nocardia is post, like an injection or some trauma, thorn prick or something. So unless he has lung lesions, it's difficult to have skin lesions alone or nocardia. Yeah. That's what we didn't keep a nocardia as a first diagnosis.
Since he has a GI lymphoma issue, maybe the drug absorption is not good. So maybe just cryptococcus which is ramping up.
Yeah, so we did a cryptococcal antigen from the blood and he didn't have fever. Also the blood culture was sent negative. So what we did is a full thickness skin biopsy. It was done in OT by a surgeon. And it is suggestive of necrotizing granulomatous inflammation with AFP. Gene expert was negative. And this was again a man. So he's yet to be started on therapy because I have to adjust lot many drug interventions. Over to Dr. Anybody has any questions? Or
we use a lot of tags with voriconazole. So, I mean, it's okay if you agree to change tag to azathioprine, but I think it can be done. It's not a absolute contraindication to start voriconazole with tag.
Yeah, because that time he had not been here. He was on R-CHOP, so that's why we decided it's better. The hematology was better to manage with a lesser drug interaction. So that's why we chose to switch him over to azathioprine.
Yeah, I agree with Nitin. We also do the same thing. We just reduce the tacrolimus dose when somebody is on fluconazole. We have a large series of cryptococcal meningitis post kidney transplant. We are writing that up, and in majority of the cases, we had used fluconazole only in the consolidation and in the maintenance phase in those patients with tacrolimus, of course.
So just wanted to say very nice case, Kirti ma'am. Just one more thing. I think sometimes when we get a yeast in the blood, it comes out as trichosporon. That is one more just to add to that list.
I think trichosporon, geotrichum, saprokeet, capitata, and all that. I'm sure we can add on to that list as well. That is a good case.
So, Kirti, actually, this case, I think, beautifully illustrates for all the conference delegates the kind of natural history of the infections that you get throughout kidney transplant. This is typical. I mean, it's absolutely textbook typical, and this is what happens once you get beyond 10 years of kidney transplant. So, any nodules, any yeast in the blood, anything, fever that's not settling, it's just streptococcemia. You have skin nodules beyond 10 years, it is usually atypical mycobacteria, but I like the fact that here the skin biopsy had shown it, which is more in keeping with what we see normally. I mean, I would not expect them to have a systemic illness. It is most likely to be, localized to the skin. So yeah, beautiful case, and this is kind of a normal thing for a kidney transplant. So really well illustrated.
I agree with Priscilla. Very nice presentation, Kirti. Complicated case. Cryptococcus should always be in your differential in renal transplant patients. For some unique, unclear reason, Cryptococcus is closely aligned with kidney transplants as compared to other solid organ transplants or stem cell transplant. So, and it can happen at any time after transplant. It can be within soon after transplant or as a late complication. For some reason, Cryptococcus-specific immunity does not seem to be developing post-renal transplant. They seem to be impaired, and I don't think that's very well studied. And as Priscilla outlined, all these pathogens should be kept in mind, and this is a beautiful example of such a thing. And these patients are very complicated, and I can't believe how nicely you managed the patient. And fortunately, the patient was able to tolerate all these complicated therapeutics.
After a few days, the patient actually becomes like your family member. They keep on coming so many times.
Right. And the one point I just want, it's not a major point, tacrofluconazole. We use a ton of tacrolimus in the stem cell setting, and we do not worry about fluconazole interaction. Fluconazole, unlike itraconazole or voriconazole, has minimal interaction with tacrolimus. So we do not make major concessions with fluconazole anytime we want to use it. Of course, tacrolimus should be used with caution, with close monitoring of tacrol levels. As long as you're monitoring tacrol levels, we use a lot of fluconazole for prophylaxis in the stem cell setting. I think the tacro-fluconazole interaction is overblown. Pharmacists create a fear in us, but I don't think one needs to be so concerned about that as long as you're monitoring tacrol levels.
So just to continue with Sir's point, where when I was in Vellore, so during the first few months of my training, I saw a consultant in nephrology, and one of the patient actually was on ketoconazole for last 10 years. Later on, I realized that to bring down the cost of tacrolimus, that the transplant physician was actually using it as a option to increase the therapeutic levels of tacrolimus.
Protease inhibitor boosting.
Yes.
Boosted tacrolimus.
I have a question for all the expert panelists. But we changed him from AMPHO because of the toxicity. Should we have continued it with a lower dose of AMPHO, or it is good that we stopped it? What are the chances of relaxing him to have again a crypto because they've not given him AMPHO anymore? That is still bothering me when it comes to the...
Yeah, I was just thinking whether the AMPHO directly caused the arrhythmia, or was it due to the hypokalemia, hypomagnesemia?
No, there was no electrolyte imbalance. He was absolutely well. Despite of so many things, he went to the ICU for the first dose. Actually, we gave it in the ward. We had actually a cold blue because it was so stable.
I would continue with fluconazole, Kirti. I would not worry about it because, giving liposomal long-term to, not long-term, but at least to a kidney transplant patient, you're at the same time, you're trying to save the organ that you've invested so much in. And unless if there was a meningitis, definitely go with the liposomal AMPHO. But then since there wasn't, and not that bacteremia is not important, but most often patients seem to do well with fluconazole. In our experience, they seem to have done well. I don't know if anybody has had a different experience.
So fluconazole is a good drug as long as it is sensitive to it.
Yes.
Especially when you use it at adequate doses, it works. And as was being pointed out, you can save some cash by lowering TAC levels. Lowering TAC.
Yeah, so we had actually, one of my cases during Hinduja, we had tried to use clarithromycin in order to reduce the posaconazole cost in a patient with mucor and all that. So all this protease inhibitor boosting, and of course there was a case study, there was a nice case report about omeprazole being used to boost the voriconazole levels. Yeah. I think I mentioned it in one of the earlier conferences as well. So the person was a fast metabolizer of VORI based on the CYP2C19. So there was a case study by somebody from abroad where they used omeprazole boosting to reduce the number of doses, and cost becomes most important in our country, but for them it was more of easier dosing.
Can I ask a question to the panelists? So I am currently consulting on two cryptos who are admitted, one with a post-renal transplant 35-year-old boy who has a fluconazole-resistant Cryptococcus neoformans in CSF and in blood, and another HIV gentleman who also has a similar picture but not grown in blood, only grown in CSF, has a fluconazole-resistant, fluconazole and voriconazole-resistant Cryptococcus in neoformans in CSF. So how do I plan his consolidation and maintenance therapy for that patient? Both.
There was an African study which spoke about all oral therapy for Cryptococcus, fluconazole and 5-FC only. I think they have so much crypto and they have so much problems with giving the AMPHO to so many people that they had considered this. So 5-FC is something which you can consider in the appropriate host with appropriate monitoring, I suppose, very, very, very difficult to give AMPHO for any prolonged period in such a patient. So that's what I would think of.
So the HIV guy actually had POSA susceptible crypto. So he is currently on POSA maintenance therapy for almost 8-9 months now. I don't know what I would do with the transplant guy, the kidney transplant guy who's currently admitted.
Let me make my comment. If you have a fluconazole resistant cryptococcus,
yes, sir,
that is pretty unusual.
Okay, sir.
So the question is, which lab did it? How reliable is this data? I have never seen posaconazole being tested. So if you have fluconazole resistant cryptococcus, you need to make sure the results are accurate. In my opinion, probably the results are not accurate. If you do have a genuine fluconazole resistant cryptococcus, you don't have any other drug of choice other than amphotericin B at this time. You cannot reliably use any other azoles. They are far inferior to fluconazole, and there would be cross-resistance if it is truly fluconazole resistant. And certainly echinocandins are not an option. So you're left with only either lipid form of amphotericin or conventional amphotericin. This is a difficult choice in a renal transplant patient. So what we have used, certainly lipid form would be the preferred way to go. And especially if you have somebody with CSF positive for cryptococcus, then I would not rely on fluconazole, flucytosine, or some combination like that, particularly in the CSF, or if you have a suspicion of fluconazole resistant crypto.
Thank you, sir.
Yeah.
So for the consolidation,
can we go for the quick third and fourth case quickly, or we stop here, sir?
9:15. You guys want to go on?
2 minutes left. It's like an exam.
We will take one more and then stop.
Yeah, I think we should stop actually because it's way past time.
Short and finish it.
We'll ask the organizing secretary. She's with us.
Okay, a quick one, quick third one.
Okay. So I'll start here. He's a 65 years male, diabetic, 25 years, ILD, diagnosed 3 years on multiple therapies, prednisolone, admitted with 3 days history of abdominal pain, bilious vomiting, few loose stools, and with breathlessness. This was the baseline CT scan, what ILD was. His abdomen was completely, I had seen him in the evening around 7:30, and he was tender all over, more on the right hypochondriac region, epigastric region. There was no rigidity as such. There was no neck stiffness, RS. He had bilateral crepes of the ILD. His respiratory rate was 30, his saturation 94. We decided to shift him to the ICU. His lactates were normal on admission. This was at around evening, and blood gas was fairly decent. Some bicarbs were on the lower side. He shifted to the ICU at 11 p.m. and we decided, the surgical people said, and they said it's a surgical abdomen. And so we decided, we sent 2 sets of blood culture and urine culture. He was started on piperacillin tazobactam after that. And we did a midnight CT pelvis, which was, we thought of possibly cholangitis, pancreatitis, or could be some acute abdomen we couldn't make out. And the CT scan was reported as normal. At 4 a.m. same night, a patient becomes hemodynamically unstable. He's breathless. He goes on inotropes. He's intubated and ventilated, and he has slight bilious secretion. Maybe he must have aspirated. His antibiotics were escalated to meropenem teicoplanin, and his blood gas show that the lactates have jumped to 68.6, requiring inotropes on ventilator. So basically hemodynamic instability with an acute abdomen. And so early morning, this patient was taken for a surgical intervention because CT abdomen, though it just showed calculi in the gallbladder, but did not show that he had a calculus cholecystitis, neither pancreatitis. But with such rising lactates and hemodynamic instability of mesenteric ischemia, though the CT did not pick up, was thought of, and these were the counts, 20,000 was the count. His bilirubin was 3.41, the liver enzymes were elevated, the CRP was very, very high, the procal was on the higher side. He was taken for, his amylase lipase were normal, and he was taken for surgery. Then in the intraoperative period, the surgeon said that the liver is looking cirrhotic and is not looking healthy. And he quickly took a liver biopsy and came out. After the surgery, patient stabilized, his inotrope started coming down. Only an appendicectomy was done. Intraoperatively, the surgeon did not find the reason for an acute abdomen. And he just did an appendicectomy and came out and took a liver biopsy. He said the liver doesn't look healthy, it looks cirrhotic. Post-operatively, he got better. He was on meropenem and teicoplanin. I do not know why. At that juncture, his lactate started coming down, his inotrope started coming down, his urine output improved, and that was the this was the case. So, what would be your differential at this juncture? And further, we decided to find out why the liver enzymes were elevated, why that cholangitis, and this is the MRI. Showing multiple extensive liver abscesses here. So, any differentials, any guesses? What could have been the reason? So, basically, summarizing, a patient with ILD who must have been on some immunosuppressant steroids, came with an acute abdomen, surgically explored, nothing in the abdomen, CT abdomen was out reported as normal. He had a gallbladder stones. So the differential for exploring was query mesenteric ischemia or could be empyema of the gallbladder, though the CT did not show because of the very rapidly increasing lactates and hemodynamic instability in this patient. And sometimes mesenteric ischemias and all that, they will not give you time with such rising lactates. And intraoperatively now, finally, he's got multiple liver abscesses.
I think of bacteria and Candida most likely.
Okay. Any other difference?
Blood culture grow, gram negatives.
So patient post-operatively was getting better and tapering inotropes, conscious level was better. But at 72 hours, he was slightly drowsy and now he had a neck stiffness. Initially, when I had examined, he did not have a neck stiffness and MRI was performed. It did show leptomeningeal enhancement. And blood cultures were after 48 hours in the late night. The technician was not sure, but she said all the 4 blood cultures are positive and it is showing some gram-positive cocci. The BCID panel was quickly put at Lilavati. I think there was some issue with the machine we had. It was negative and the repeat sample was sent outside. Any guesses what it could have been? The technician said they're not very sure what is it like.
So this is a syndrome of severe sepsis, liver abscess, meningitis in a lady who's been heavily exposed to steroids for quite some time. And liver abscess, bloodstream infection, meningitis, exposure to steroids. I was be thinking of strongyloides hyperinfestation and translocation of gut bacteria from there into the blood and into meningitis. So since it is a gram-positive cocci, I would be thinking of enterococcus in this situation.
Enterococcus.
Any other differentials?
Other thing, had it not been a GPC, I would be thinking of a hypervirulent strain of Klebsiella.
Okay.
I think if this GPC is not, cons, etc., it cannot be because it's 4 out of 4. I think enterococcal meningitis, I would completely agree with Dr. Vikas. From the time you said loose stools and long-term steroids and comes in shock, I think the only thing that was brewing in our mind was strongyloides hyperinfection.
Listeria,
Listeria.
I think it's gram-positive cocci.
But see, the technician is not sure.
Okay, then if the technician is not sure and we look at the smears and it's not, then it's fine.
The CSF showed that the proteins were very high, the sugar was normal, and there was 192 cells here, which were predominant lymphocytes. The CSF gene expert cryptococcal antigen was negative. The CSF TV pyrosequencing was negative. And the liver abscesses, the biopsy showed that there was multiple abscesses and the liver was cirrhotic. So this was and the next day when we went and it showed very clear colonies on this blood culture plate. Any differentials? What could be these colonies?
Nocardia?
Nocardia will be white, chalky white.
White chalky.
They're very clear, tiny, small colonies, which is very characteristic possibly of certain pathogens. Anyway, I'll run through this, and the blood culture grew listeria, and that night which we had sent, next day morning we got to know that BCID panel of the blood, which all the 4 bottles grew, was also listeria. So in clinical specimen, this is from Mendel, the organism may be gram variable and look like diphtherites, cocci or diplococci. Laboratory misidentification diphtherites, streptococci or enterococci is not uncommon, and the isolation of diphtheroid from the blood or CSF always should alert one to the possibility of listeria monocytogenes. CSF biofile was negative. I do not know, maybe it was blood treatment. And if you see this, you may not get classical neck stiffness and neurological findings in 60% of the patients. So many patients with listeria, bacteremia, or CNS infection give a history of antecedent GI, and then usually that illnesses occur 24 hours, range from 6 hours to 10 days after ingestion of inoculum of bacteria around 1 to 3 days. And there were very few cases reported about disseminated or liver abscesses due to listeria monocytogenes. And usually if you see those people who have meningitis and bacteremia, all of them had died, and especially this was more with, those people who had liver, meningitis and bacteremia. So this patient took a DAMA and went home. So this was again a report of community-acquired listeria monocytogenes in adults, and all the patients were immunocompromised of more than 50 years of age, and the classical triad of fever, neck stiffness was seen only in 40% of the people. So you may not have typical neck stiffness and listeria. Typical CSF findings predictive for bacterial meningitis may be absent, just like in this case. And the treatment is usually ampicillin or meropenem, but I just come to meningitis doses should use all patients in the absence of CNS or CSF abnormalities because of high affinity of this organism for CNS. Relapses and treatment failures are reported in those with meningitis treated for less than 2 weeks. Therefore, the treatment for 3 weeks is recommended for all cases of meningitis, especially listeria. Bacteremic patients without CSF abnormalities can be treated for 2 weeks. Patients with thromboencephalitis or brain abscess should be treated for at least 6 weeks and followed by serial MRI imaging studies follow-up. Endocarditis should be treated for 4 to 6 weeks. Various combinations ampicillin plus gentamicin was used for this patient, but ampicillin plus TMPX is better than ampicillin plus gentamicin. Chloramphenicol, a lot of failures, imipenem, complete failure, meropenem, on it, you may have, failures. Vancomycin, though in vitro shows susceptibility, in vivo, it may not work. Cephalosporins, no, it does not have any role in listeria. So I'll stop my presentation here. So basically, this was a case of disseminated listeria liver abscesses with meningitis, presenting as an acute abdomen.
Is this case presented in an ID conference will always prompt strongyloids?
Correct. So this So actually, we send the sample to Hinduja because there's some issue with it. Because I said keep 4 bottles positive, and that too, the technician saying gram positive cocci or UBI, not sure. I said I want a diagnosis right away, middle of the night. It was Sunday night, and midnight, 2 o'clock, 3 o'clock, I got an answer that this is listeria.
So that empiric meropenem was probably helped him because...
Yeah, that's what. So the drug which helped him. Another differential was melioidosis, again in this patient who can present with CNS and liver involvement. So that was another differential in this patient, apart from E. coli and whatever, translocation in the gut or all these pathogens.
I think the liver being cirrhotic, etc., also was like a very important risk factor around here.
Yeah, correct. So which was the patient was not aware at all, and so it was only intraoperatively we came to know about it. So he was immunocompromised apart from this, whatever is taking for ILD. And so a rare presentation of listeria to begin with and followed by meningitis. Because when he came, he did not really have the next case. Kirti, you want to quickly put some, depending on the chair.
Okay, I think we should stop.
I think stop. Yeah.
Stop now.
Yes.
Okay.
Okay, we'll meet tomorrow.
Yes. And
thank you all and good night.
very happy to see all of you.
Thank you.
Hope we can meet physically soon.
For this opportunity. Thank you so much.
Thank you so much, Dr. Parul, for moderating the session, and thank you, everybody. Thank you.
Good night.
Thank you.
Bye-bye.
Good night, everyone.
Very good night, and hope to meet everybody very soon.